بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين. Good afternoon, ladies and gentlemen. Welcome to the Eastern Province virtual activity on pulmonary hypertension. I am glad that in these 2 days, Friday and Saturday, 16 and 17 of October, we invited eminent speaker from our country to talk about important topics, which is pulmonary hypertension. Pulmonary hypertension is a disease. You can see most of the specialty in internal medicine is involved, including cardiology, pulmonary, rheumatology, intensive care, nursing, social worker, surgeon. So almost everybody involved in the care of patient of pulmonary hypertension, whether diagnosis or treatment or follow-up. So our webinar, the first one will be presented by Dr. Abdullah Dalan. He will talk about pulmonary hypertension diagnosis, then followed by Dr. Hussam about pulmonary hypertension risk stratification, then Dr. Majdi Idris about pulmonary hypertension treatment, then role of echo in pulmonary hypertension by Dr. Mustafa Rifai, and right heart cath in pulmonary hypertension by Dr. Hisham Hussein, management of pulmonary hypertension in pregnancy by Dr. Nawal Al-Qubaisi. So as we know, the commonest, it's a rare disease, especially primary pulmonary hypertension is a rare disease. But if we encounter the pulmonary hypertension secondary to left heart disease, 3 to 4 million in United States having pulmonary hypertension secondary to left heart disease. And this is managed mainly by the cardiologist, followed by pulmonary hypertension secondary to chronic lung disease, and then related to chronic thromboembolic disease, and then primary pulmonary hypertension, which is the least causes. So here, as I said, pulmonary hypertension is uncommon, but it's a life-threatening disease. Diagnosis is usually late and is associated with progressive clinical deterioration and premature death. Pulmonary hypertension remains clinically silent until right heart failure. And diagnosis require specialist skills, invasive diagnostic procedure like right heart cath, and diagnosis not confirmed until up to 3 years from the initial symptoms presentation, and prognosis without treatment is poor. So our aim from this course is to identify the cases of pulmonary hypertension in cost-efficient manner. So to have rapid and accurate diagnosis of pulmonary hypertension, and really to have effective treatment to improve quality of life and prognosis. And you can see here the commonest cause of pulmonary hypertension is group 2, which is left heart disease. And in the United States, they have 3 to 4 million of pulmonary hypertension secondary to left heart disease. The second group is group 3, which is pulmonary hypertension secondary to chronic lung disease, COPD, and interstitial lung disease. And the third group is group 4, which is pulmonary hypertension secondary to chronic thromboembolic pulmonary hypertension. And the fourth group, which is group 1, pulmonary hypertension, whether idiopathic or other causes. Thank you. So now I introduce Dr. Abdullah Dalan. who is the president of his consultant pulmonary at King Faisal Specialist Hospital, and he's the president of Saudi Association of Pulmonary Hypertension. Dr. Abdullah Abdullah.
Thank you, Mustafa, and thank you for Johnson & Johnson for organizing such a great meeting. For my colleagues we are having 187 participants. This is very good news, in fact, for us. Just to let you know a brief background about this meeting, SAF has been doing this for many years in the past. These are awareness days, normally distributed over the different parts of the kingdom. We try to make it over 1 or 2 days and make it simple, basic diagnosis and management of pulmonary hypertension. And this year we started, this quarter we have started with Dr. Mustafa Rifai from Al-Babtain Center, him and his colleague from the Eastern Province. So I would like, on the behalf of my colleagues from SAF board members, to thank you, Mustafa, and thanks all the group in the Eastern Province, our colleagues there, for putting together such a good program. And we're hoping nearly 200 participants now, mashallah, will get some benefit from this. As you all know, and as Mustafa said, the burden of pulmonary hypertension has been increasing over years. And I think the ability to make a diagnosis has improved a lot in the country here, alhamdulillah. And SAF has played a major role under leadership of my colleague and friend, Professor Majdi. And we have continued this over the last, let's say, 13 years or 14 years. I think the awareness days have played a very good role with a positive impact on increasing the awareness of pulmonary hypertension across the country. And since we started doing these activities, the referrals to the big centers have increased over the last 15 years or so dramatically. And in fact, in the big centers now in Riyadh, at least in our center, and Majdi have been telling me, and Majdi and Sam as well, that nearly every week we have 1 or 2 referral new cases from different parts of the country. I think this has been a successful journey over the years, and we will continue this in SAF, obviously. And with the era of pandemic, that has changed to virtual meetings, and in a way that has made things much easier when it comes to logistics, and less amount of travel, less amount of expenses, and easy communication. So I think this is going to be continued like this, even if the pandemic is over. We will do some sort of a mixed activity in SAB between physical activities as well as these virtual meetings. So thank you again, Mustafa, for this activity. And we will start with my talk. The program has been made in a way that we start from the basic, simple diagnosis of pulmonary hypertension, and then risk stratification, as you illustrated, Mustafa, and then the treatment, and then tackle different aspects of pulmonary hypertension, whether diagnosis or treatment, and then focusing on few subspecialties of pulmonary hypertension: connective tissue disease, congenital heart disease, and CTEP, and so on and so forth. So Mustafa has given me the first talk, and it's going to be about how to diagnose pulmonary hypertension. And in fact, I made it relatively simple, and many slides have been already used before. I'm sure those who have been attending our meetings in the past see these slides, familiar with them. But it is made simple because the aim of this awareness day is to go back to the basics. And we have many participants who have been either just starting to see patients with pulmonary hypertension, or they have already they have not been starting, and they're planning to practice this part of medicine. And that's why it should be, in a way, essential basic information. Of course, because it is a diagnostic talk, and there was nothing mentioned about classification, this is going to be part of it as well, the classification, as well as the definition of the disease. So I hope you can see it's shared now with you. I hope it's clear.
Yes, it's clear.
Very good. Okay. All right, so Bismillah ar-Rahman ar-Rahim. I made actually a bit of a change in on the title, Mustafa, if you allow me. I made it like this: PH early diagnosis, different types, different prognosis, and different treatment, because this is how the approach to pulmonary hypertension should be, starting from considering it or tackling it as a multiple spectrum of diseases rather than one disease. Okay, as you all know, the definition of pulmonary hypertension has been changed in the last 6 World Symposium, and the diagnosis now, the definition now is when the pulmonary hypertension, the mean pulmonary artery pressure more than 20 millimeter mercury, with the pulmonary artery wedge pressure less than 15, and the PVR more than 3 wedges. So this is what is called the pre-capillary pulmonary arterial hypertension. So the pH, if you say pH, not PAH, you mean a clinical hemodynamic status where the mean pulmonary artery pressure in the pulmonary circulation more than 20 millimeter mercury. So, and it has been classified based on the hemodynamics classification to pre-capillary pulmonary hypertension that I just mentioned earlier, post-capillary pulmonary hypertension when you have a mean more than 20. Now, by the way, nobody is considering 25, and I think all the practice now is at 20, and the pulmonary wedge pressure is more than 15 with a normal BVR. And there has been, of course, as it is the case in medicine, many mixed cases when you have a pre-capillary pulmonary arterial hypertension and post-capillary hypertension mixed in one's disease. It's called combined pre and post pulmonary hypertension. Few facts before we go to the diagnosis. You have to put in mind when you make a diagnosis, when you approach a patient with pulmonary hypertension, that these patients, your goal is not only reaching the right diagnosis, your goal is also reaching an early diagnosis, because as it is clear now and has been clear for decades that the majority of patients present late in the disease. So majority of patients in the international registries present functional class 3 and 4, about 75% in French registry, and about more than 65% in our registry. And it's the same also, this is the Kingfisher registry, but also in other registers in the country. So the diagnosis is difficult, but the patient present also late. And this has been shown clearly that once the patient present in functional class 3 or 4, their histopathological changes and hemodynamic changes have already been too late for curing the disease, put it this way. So because majority of patients present late in the disease, at a histopathological level, the changes are becoming relatively irreversible. The hemodynamic numbers are also very bad. If you see cardiac output starting to drop, pulmonary artery pressure, pulmonary right atrial pressure, and pulmonary vascular resistance have already been very high. So putting this in mind and trying to make a diagnosis much earlier in life is one of the goals beside having a precise diagnosis. If you look at these 3 European studies, registries in fact, and this is the bad news. Majority of patients unfortunately present also in the low risk group. So low risk group, only 23% in Swedish registry, 12% in Compera, which is Germany and some other countries registry, and French is only about a quarter of patients present in the early risk group or low risk group at baseline. And if you look at the mortality rate, that means majority, in fact, in group low, intermediate risk and high risk, and see the mortality rate for these patients. For instance, for the high risk group, the mortality, this is the annual mortality rate. Please pay attention to this, is about 25% annual mortality rate for patients who present with high risk group in a high risk group area. So it's a very devastating disease, not only presenting late, but all those who present late, they have very high mortality if nothing has been done for these patients. We have also known from the literature that early intervention can actually decrease the time to clinical worsening. And we also know, this is in general, in idiopathic and in PAH group, in subgroups of patients with, for instance, scleroderma, if you do screening for this patient and you pick up the disease early in the course, and you intervene, the prognosis of these patients is much better with early intervention. I'm sure my colleagues have seen this many times, but this fits the purpose of this talk. And in a way, I want really to make sure that people understand what is meant by reaching the appropriate diagnosis, even in the PAH subgroup, and reaching the not only the appropriate diagnosis, the subgroup of the subgroup disease. Because remember, at the beginning of my talk, I said this is a spectrum of diseases. We have to approach it this way rather than a single disease. So these are 5 cases from our real life practice at our center. The first patient is 27-year-old male with mean pulmonary artery pressure of 70, wedge pressure normal, very severe low cardiac index, and very high PVR. The second patient is 21-year-old female, relatively similar hemodynamic picture, as you could see here, with different severity. 91 mean, normal wedge pressure, very low cardiac index, and high PVR. Third patient is another young female with severe pulmonary hypertension, that is pulmonary arterial hypertension. And then the fourth case is 19-year-old male with severe pulmonary hypertension, and the fifth case is the same, basically. 27-year-old female with severely elevated pulmonary arterial hypertension, normal wedge pressure, and low cardiac index, and very high PVR. So if you look at these 5 different cases, you will say these have the same diagnosis because they have high mean pulmonary artery pressure, low wedge pressure, low cardiac index, and high PVR. And then I'll let you know about these cases later in the talk to prove the point, which I will reach also at the end of the talk. All right. Remember, the classification of pulmonary hypertension is as follows. The group 1 pulmonary arterial hypertension is PAH, pulmonary arterial hypertension, idiopathic, heritable, drug-induced, and associated with connective tissue disease, HIV, portal hypertension, congenital heart disease, and schistosomiasis. This is the updated one here in the 6th World Symposium on Pulmonary Hypertension. They put here the PAH with long-term response to calcium channel blockers, and PAH with overt features of venous capillary involvement, whether a PVOD or pulmonary capillary hemangiomatosis, or even idiopathic with overt feature of vascular involvement, and then persistent pulmonary hypertension of the newborn. So this is group 1, the PAH group. And as you could see, even in the PAH group, it's actually multiple diseases. So this is very important. And the diagnosis is, you have to reach the diagnosis and you have to treat them differently. And by the way, treatment in general is probably the same, but the prognosis of these patients and the outcome is different. And then you have a group 2 patient, PH due to left heart disease. And you could see here clearly that we're not saying here PAH, we're saying here PH, pulmonary hypertension due to left heart disease. And then pulmonary hypertension due to chronic lung diseases and chronic hypoxia. And then PH due to pulmonary artery obstructions, which is basically the most important part of it is chronic thromboembolic pulmonary hypertension. And this is very important to reach either to rule in or rule out because the treatment is surgical for majority of patients. And then you have group 5, which has unclear or multifactorial mechanisms, like the most famous part of them is basically hemolytic anemias, like sickle cell disease. Now, this is the diagnostic algorithm, and the only way to reach the right appropriate diagnosis is basically by following that diagnostic algorithm. This is the older one, and there is not much changes if you compare it to the new one. This is the new one, except the fact that they put here, you have to think of a fast-track referral for selected patient immediately to a PH expert center. For instance, if you have a patient with high risk patients, let's say you saw a patient with pulmonary hypertension, your clinical judgment is pulmonary hypertension, you did echocardiogram and it showed pulmonary hypertension, and you know for sure this patient has bad, severe stage of pulmonary hypertension. Instead of going through the algorithm, this algorithm, for instance, maybe it's better to send them, to send the patient to the referral center. So let me go over the clinical feature, and they will go over the diagnostic algorithm quickly. Problem with pulmonary hypertension that the symptoms, the general symptoms, are actually similar and shared with many other respiratory illnesses. So you're having shortness of breath, fatigue, weakness, syncope, dry cough, and abdominal distension, lower limb edema, especially the first ones, the shortness of breath, the whether it's at rest or on exertion, some fatigue and weakness can be shared with many diseases. And unfortunately, this is one of the main reasons for delaying the diagnosis of pulmonary hypertension. And this has been mentioned already by Mustafa that in many parts of the world, in fact, the diagnosis reached after 1 or 2 years. This has been documented in literature. And I think we're not similar, we are not different from the rest of the world. So, but always please put in mind that if you have unexplained shortness of breath in younger or middle-aged person who has normal looking chest X-ray and normal clinical exam, whether the heart and the lung, then please keep in mind that pulmonary hypertension is actually a differential diagnosis here. So actually, if you have this in mind, it will be always better and maybe quicker to reach a diagnosis. And many patients, unfortunately, have been diagnosed wrongly as asthma or COPD or some other things and treated wrongly for a couple of years or more than that. Let's say now we go over the, let's say now you saw the symptoms, you heard from the patient the complaint, and you have in mind that PH is one of the differential diagnoses. What do you do next basically is echocardiogram. That's the first thing in the diagnostic algorithm. And without going in much details for the time issue, we have categorized the probability of echocardiogram findings for pulmonary hypertension. So if you have the tricuspid velocity, tricuspid regurg velocity more than 3.4, that the likelihood for this is a high probability echocardiogram findings for pulmonary hypertension. If you have the tricuspid velocity, regurgitation velocity less than 2.8 milli per second, then meter per second, this is most likely not related to pulmonary hypertension. So maybe you need to go for further looking for alternative diagnosis. And as it is the case in medicine, there is always this gray area. If you have tricuspid velocity between 2.8 and 3.5, 3.4, you look at other features of echocardiograms that could explain pulmonary hypertension. For example, if you have concave septum, if you have dilated chambers of the heart, especially the right side of the heart with the atrium of the ventricle, and so on. So we have some pericardial effusion. Maybe even you have congenital heart disease picked up by the echocardiogram. Maybe there is mitral stenosis, aortic stenosis, and so on and so forth. So if you have the velocity that is less than 3.4, but in that gray area, but you have other features suggestive of findings of pulmonary hypertension, then this patient should go through the protocol for diagnosis of pulmonary hypertension. Obviously, you look at pericardial effusion findings. It's the importance of that. Obviously, if you have a patient already advanced pulmonary hypertension, presence of pericardial effusion is normally a bad prognostic sign. We have mentioned many other findings in the echo. Of course, the chamber size we have already mentioned, the IVC diameter and inspiratory collapse during the inspiration as another indicator of pulmonary hypertension. I don't want to go into details of the echocardiogram findings, but the echo is normally #1 step for making the diagnosis of pulmonary hypertension. And from that, you go to the rest of diagnostic workup. These are the rest of diagnostic workup. You do chest X-rays, you do ECGs, you do PFT, including the LCO, and high resolution CT scan and CT scan with pulmonary angiogram as well. By doing this, you are actually excluding or even including the secondary causes of pulmonary hypertension. For instance, in the ECG, although it's not diagnostic, but you can find many findings that can suggest pulmonary hypertension, like prominent p-value, right ventricular strain pattern, and ST segment depression in the lateral leads, and all these things that can give you a hint towards pulmonary hypertension. In chest X-ray, although it's a very simple and a very non-costly diagnostic tool, but you can actually find a lot. simply you can rule out chronic lung changes, in a good number of patients. But also you can find other features that can be suggestive of pulmonary hypertension. These two patients, for instance, are actually from our practice. The first one with severe pulmonary hypertension, you could see the right pulmonary artery is almost aneurysmal. This is very, very strong indicator that this patient has pulmonary hypertension. But this is maybe the end of the spectrum for such severe cases. In milder to moderate cases, you have a prominent right main pulmonary artery, more than 80 millimeter or more than 60 millimeter, and that can be indicator for pulmonary hypertension. But in this lady, this is really bad. This is a patient who has been on who has been diagnosed with idiopathic pulmonary arterial hypertension. She's on prostacyclin infusion for the last 12 years, I guess, or so. In this patient, for instance, the lungs are clear, and this is very important to rule out secondary causes, but look at the heart. The heart is actually big, rounded, and this patient, unfortunately, she is idiopathic pulmonary arterial hypertension, quite advanced, but she presented, in fact, with pericardial effusion. So she was already a later stage, and pericardial effusion, as you could tell from the chest X-ray, that has been confirmed by echocardiogram. Chest CT scan is also important, part of the diagnostic workup to rule out interstitial lung diseases, but also there are some subgroups that you could also make a diagnosis by having a high resolution CT scan made, for example, done for this patient. For instance, this patient and this patient is ours. If you look at deeply, I don't know if you could see it, but there are nodular bilateral diffuse nodular ground glass changes, a little bit of septal thickenings, not much here, but it's there. In other cases, the patient has also some prominent lymph nodes. So this is a patient of ours, and this patient has PVOD. And by the way, this patient has been confirmed with PVOD by the genetic test. So from looking at the CT scan, high resolution CT scan, it could guide you that this patient with pulmonary hypertension, with these CT scan findings, you can make a diagnosis of PVOD as well. Because remember, PVOD, you cannot do lung biopsy for these patients. So it's actually a radiological plus genetic testing diagnosis. Now, once you rule in or rule out group 2 or group 3, for instance, if patient has findings suggestive of group 2 or findings suggestive of group 3, you go, then it's a PH, not PH, and you treat accordingly. But if the patient has no findings suggestive of left heart disease, or no findings suggestive of a chronic lung disease, then this patient should be continue to go through the diagnostic workup. Then the next step will be a PQ scan. This is the CTEF, a new protocol based on the 6-minute walk, 6-word symposium, the last one done, but it's basically is the same, not drastically different from the older one. So what you do a PQ scan. Why is that important? Because you have already done a CT angiogram during your initial workup. It's important because a small group of patients who has very distal disease can be missed by regular CTP study or CT pulmonary angiogram. And although now in very good centers with very experienced radiologists who can actually find all the chronic thromboembolic pulmonary hypertension CT scan changes, to a great extent that they could even rule out pulmonary CTEF by CT pulmonary angiogram. However, it's still recommended to do VQ scan, and these are the changes for a VQ scan in idiopathic pulmonary hypertension. It is actually peripheral, some not mismatched defect. However, these are the changes of CTEF. You could see a lobar or even sometime multi-lobar mismatch in the lungs. This is a patient of ours who have normal CT angiogram, and this is her VQ scan. So with having a normal CT angiogram, she has actually abnormal VQ scan. So the diagnosis of this lady was chronic thromboembolic pulmonary hypertension. Again, the reason is maybe you will treat this patient this patient particularly was inoperable because it has very distal disease. This patient can be now treated with balloon angioplasty, for instance. Okay, so that's basically the need to rule out CTEF. And I always put this picture because why it's important to reach the diagnosis of CTEF or the appropriate diagnosis in general, including CTEF. because this is the treatment for CTIF. If you did not reach the appropriate diagnosis and the patient has CTIF and did not have surgery, then this patient cannot be cured. This is very, very important. And this is the only form of pulmonary hypertension who is potentially curable or treatable at least. Now, you did the VQ scan and you did the CT angiogram and the patient has none suggestive of CTIF or anything, and the patient still have pulmonary hypertension, obviously by the echocardiogram. Now, or a patient is actually a patient with CTIF, then this is the stage where you go actually for right heart catheterization. And you all know in the right heart catheterization, you have numbers that you cannot get them by echocardiogram. And the most important one of these numbers are actually the mean pulmonary hypertension, although obviously you can calculate it by echo, but precisely the best way is actually to get it when you are already inside the pulmonary vasculature. So mean pulmonary artery pressure, cardiac output / index, and capillary wedge pressure, obviously, and you have to calculate obviously the pulmonary vascular resistance. But also more importantly, you do vasodilator test. This is very important. And this also carries a very important information that has impact on treatment, prognosis for these patients. As you all know, it is the gold standard, the right heart catheterization, and there will be a talk dedicated for right heart cath later. And it's actually class 1C for when it comes to the recommendation. Now, the latest recommendation for this should be done for group 1 pulmonary arterial hypertension. Obviously, not all of them. I'm talking about the vasodilator test now. It's not the right heart cath. You know what? I think there is a slide for right heart for the vasoactivity test. So the right heart cath should be done. This for all PAH group, obviously, and also some patients with group 2 and group 3 when their numbers are, let's say, out of proportion of their metabolic illness or respiratory illness, and obviously for patients for chronic thromboembolic pulmonary hypertension, because this is important prognostic value when the patient is undergoing the pulmonary endarterectomy, and obviously for all patients who are going to be having lung transplantation. But this should be done precisely, because as simple as taking a pulmonary capillary wedge pressure, if it's not taken properly, for instance, at the end of the expiratory reading, then it can be misleading. Remember, the number 15 is the magic number, for instance. For example, if you have a patient who has a wedge pressure of 16, but not taken properly, then you put a patient in different category. If the patient has a number of 14 or 13, and this, because it's not taken properly, then again, you put a patient in different category. So it's very important to keep in mind that doing a right heart catheterization is not simply just by doing it and taking numbers. You really have to have an expert cardiologist who have done many of these procedures and who know how to get the right, absolutely right numbers for these patients, because it will make a big difference. And believe me, and take it from me, we do this, we face this almost every day. When you have numbers that do not match the clinical situation of the patient, you are in a very big dilemma. And you don't want to repeat right heart cath for a patient every now and then, because this is very invasive procedure. So taking appropriate, precise numbers is very, very essential to categorize your patients. Not only the pulmonary arterial pressure, for instance, calculating the cardiac output, whether using Fick equation or thermomodulation, is also very important. If it's not done properly and you calculate the cardiac output wrongly, your PVR will be also wrongly, because it is a calculation. So again, this is very, very important. Vascular activity test, I have already mentioned this, is very important, and it should be done for idiopathic pulmonary arterial hypertension, heritable, and drug-induced. And the reason is explained by this case. I can tell you this being presented hundreds of times, but I'll go over it quickly. This is a patient who have been seen in our center a long time ago, in 2003, with severe pulmonary hypertension. She was diagnosed at that time with idiopathic pulmonary hypertension. This is her mean pulmonary artery pressure. At that time, it was 48. Her wedge pressure was normal, and she was started for like 6 or 7 years on sequential combination therapy. Then we started seeing her sometime in 2011 or 12, I forgot, at that time. And we looked at her numbers. For the first few years, she did well, but then she started to go down. And then we started seeing her in, I think, 2013 here. Her numbers started to go down. Clinical status worsened. Her 6-minute walk test has worsened. So we decided to repeat her CAT because that CAT was done long time ago by a different team. And this is what we found. I mean, we found her mean pulmonary artery pressure has worsened dramatically compared to the one done in 2003. It was 48, now it's 81. Cardiac index still low. But when she was given the nitric oxide in the cardiac CAT, during the cardiac CAT procedure, her mean came down to 40. So dramatic decrease in her pulmonary artery pressure. So very simply, this patient was a responder to start with, and she should not have been treated with these expensive medications. And the simple action for this patient was basically to stop all of these expensive medication and start her on calcium channel blocker. And she did well. Until now, she's doing well on calcium channel blocker. But putting in mind that vasoreactivity test is not only important to differentiate patients who are calcium channel blocker or not, because it's actually, this simple differentiation carries a lot of information with it. The way to treat, the prognosis for these patients, and many other things. So let me go back to the first 5 cases that I introduced to you. Same hemodynamic compromise, same high mean pulmonary artery pressure, low wedge pressure, low cardiac index, and high PVR. So all of them are actually pre-capillary pulmonary arterial hypertension. But in fact, if you go for this spectrum of disease, remember, they are actually different. The first one is idiopathic pulmonary arterial hypertension patient. The second one was pulmonary arterial hypertension secondary to congenital heart disease. The third one was PAH secondary to scleroderma. The fourth one was an 19-year-old male who has actually PAH secondary to BVOD. And the fourth one was a CTEF patient. And remember, CTEF will be treated by surgery. PVOD, this patient did not tolerate the vasodilator therapy, ended up having lung transplantation about 6-7 years ago. Scleroderma and congenital idiopathic, they may have, you treat them the same approach with combination therapy, but the prognosis is actually different. The outcome of these patients is different. So it's very important to reach the appropriate diagnosis going through the diagnostic algorithm. This is take-home message number 1. Remember that PH is actually a number of diseases, not one single disease. This is very important. Number 2, by going through the diagnostic algorithm, you will be able to reach the appropriate correct diagnosis. Once you reach the correct diagnosis, obviously you start the goal-oriented therapy with combination therapy, and this will lead hopefully to a better outcome. Thank you so much.
Thank you so much, Dr. Abdullah. I think the second speaker, the question will be at the end of the session. So the second speaker will be Dr. Majdi Idris.
Now, I think second speaker is
Dr.
Hussam talking about risk stratification.
Yeah, Hussam will talk about pulmonary hypertension risk stratification. Dr. Hussam, he is a consultant pulmonologist at King Fahd Medical City in Riyadh. He's a senior consultant and he has a great interest in pulmonary hypertension. Hussam.
Assalamu alaikum. Good afternoon, everyone. Thank you very much, Dr. Mustafa, for the invitation and the introduction. I hope you can hear me clearly. I was, of course, the thanks goes also to Janssen for sponsoring these activities. But thank you, Abdullah, for the comprehensive introductory lecture that you gave. And I will continue from where you started. Since you stressed the importance of establishing a very good diagnosis from the beginning, very accurate diagnosis, because this is the most important step that we can take it from further. Doing a cath or establishing a diagnosis, of course, is meant to lead to a treatment, and the treatment is meant to alter the course of the disease and improve in the survival. And that comes through some clinical assessment that we have to perform. on the time of the diagnosis and during our regular follow-up afterwards. So the clinical assessment becomes really a key important part. I mean, medicine is not about radiology and hemodynamics. You still have to practice doctoring and physical examination and the clinical assessment in order to determine, is your patient fitting the clinical picture? Is he responding to the therapy that you're giving him, or he's deteriorating and you have to perform further measures? Pulmonary hypertension story is relatively new, but it's not that new. The first publication about the meaningful information from the disease came from the NIH Registry that was conducted in the 80s, about like 30 plus years ago, and it showed that it's a disease with bad outcome. No treatment at that time. They were just prospectively following up patients who fulfilled the diagnosis of primary pulmonary hypertension at that time according to their definition and the classification. And it was noticed that the mortality rate between 1 year, 3 years, and 5 years is horrible. So these are usually young group of patients who have right heart failure, and with that therapy, the mortality rate is extremely high within short period of time. And from then, they were looking at the data, and it was basically looked at mainly from a hemodynamic point of view. They realized that there are some cut points where people tend to do better if their mean pulmonary artery pressure is less, if their mean right atrial pressure is less, as very clearly shown in this graph, and if their mean cardiac index is less. So the higher these hemodynamic data is in the cath lab at the time of the diagnosis, the worse that they tend to do. And of course, the hemodynamic usually is reflective by clinical features and consequently mortality outcome. Later on, therapy became available, and this is the data after therapy. This is from the early 2000s. The only therapy was epoprostenol, the magic drug that everybody is scared from and not using at large scale. And even with that therapy, the only thing available, still people tend to die. And there was a very clear distinction between the functional class at the time of a presentation, how they will respond to therapy. It was clearly like, of course, these patients tend to be more severe than the ones that we see because they were not even talking about PH before functional class 3, and they tend to have a more delayed in diagnosis. And of course, there's very limited options for therapy. So that's partly why they are sicker. But the people who present with functional class 3 tend to do better at the baseline and after treating them with epoprostenol therapy. And this is something that was noticed back then, and we continue to notice it even today. Another analysis of the data, I think this is from French registry as well, showing people who walk more, they tend to do better. Now, the arbitrary numbers, that's what was shown by the data, but the idea is the longer 6-minute walk they do, the better survival they have. And this is something that was very clear even from the American data. Another parameter people will always look into these patients is the echocardiographic, and they also noticed that there are some echo features that are supportive of a better prognosis than others, including the right atrial size, including the presence of pericardial effusion or absence of pericardial effusion, and the left ventricular eccentricity index. And it was clearly mentioned, and these are published on an individual specific parameters among the patients before and after and at follow-up with terms of survival. Of course, the biochemical variables were very important. Some people probably we don't do this much clinically. Uric acid can be looked at as an inflammatory marker, and sometimes we see some probably old physicians use uric acid as an indicator of inflammation. But even as a uric acid, the higher the uric acid, the worse the outcome they had, and they clearly mentioned here. BNB we are all familiar with. It's whether it's the pre-BNB or the pro-BNB that we are more using nowadays. The higher the BNB, the worse the outcome they tend to have. And we're talking about short period of follow-up here between 3 and 4 years, and the survival was clearly different. And the troponin is another biomarker that is being looked at for the the outcome as well. So putting these all together has led the idea of, wait a minute, what does all that mean? We don't look at patients from an echo perspective or from their BNP perspective. It has to be looked at a comprehensive level. And one is the important one, to me, this is an important question, is how can I guess or predict which patient is going to do better in the midst of all these data. Of course, there will be clinically some differences between people might have a higher BNP, but a better walking distance and vice versa. So I think this is an idea that has been in the mind of all physicians. How can I guess? And the human beings always are curious. They are trying to figure out what will happen next. And this is the probability theory and the probability science. And they were thinking, can we detect or determine which patient is going to do better, or unfortunately he is at higher risk of doing worse? And the other important part, this by itself is important, but how can that reflect on my management? And the previous data that I showed you, it was descriptive. It was noticing that these patients who have higher numbers tend to do worse than others. And this is, again, we are probably today going to show you between my lecture and the treatment lecture that this is becoming readily available in clinical exams. So the assessment of the patient at the diagnosis and at follow-up can be comprehensive, can sometimes be complex, but it includes what we talked about: hemodynamic data, whether it's repeated cath or the initial cath the patient has before treatment, the echocardiographic data, exercise testing data, whether you do the simple 6-minute walk test, or some centers they used to do CPET, although we don't have much CPET in the kingdom. Clinical assessment, again and again, some features are supportive of worse outcome. When a PH patient comes in with syncope, it's not being looked at as somebody who's getting out of breath when they are in the market or so. And of course, we look at the biochemical data and markers that are readily available for us. That question was even raised from the NIH registry. They looked at the data, and they said this is a prospective data, and they have very good numbers, invasive hemodynamic numbers, and that's the main thing that they looked at in the registry. And they come up with an equation. Don't worry about the numbers, but they factored in the mean pulmonary arterial pressure, the mean right atrial pressure, and the cardiac index. And they followed these patients and they put it in an algorithmic fashion and a mathematical equation in order to predict the outcome. It was very complicated, of course. It did not fly much. Sturich is the one who did this equation. I worked with him. He probably is the only one who used it at that time. But we realized early on that this is not going to be probably flying. With the limited availability of the data, that was the only thing available, and it was very limited in its use, and today nobody is looking at it. I'm using this as an entry to the next level of risk assessment and the prediction model that has been developed over the years and improved upon. Now, that was early on. We didn't have much data late 90s. We did not have much therapies late 90s. But with the years, with the interest of pharmaceutical industry and the interest from the clinical and scientific point of view in the disease, there became available multiple agents. And I think by the year 2005, the major 3 classes of medications has been available and approved, and people start looking at what am I going to treat my patient with? Again, they looked at these therapies as individual. When you look at the studies, it was short-lived, and the study will show with and without therapy. At the time, there was a placebo arm was probably ethically acceptable, and there become available multiple medications. So clinically, people were trying different things. There is nothing in the guidelines, including the PH guidelines, the World Symposium guidelines, what to use and which one to use. This came 2005 from Germany, and they start looking into, like, why don't we come up with a protocol? We're going to treat these patients. And the protocol basically was supportive of something that everybody did, which is adding different therapies to the patients without having a clear guidance and without having approval by any body like FDA or the European Society. Even insurance companies were giving them difficulties. They came up with a protocol, and they noticed what happens to the patient when you escalate the therapy according to some target that they are trying to achieve. And this is the result of the study. The upper graph shows the data when you have followed this treatment-oriented goals. When you are trying to achieve the goal is achieved, you're good. If it's not achieved, you add therapy. I'll show you their algorithm. And they compared it to the historical data from their center, whom they did not follow this strategy with, as compared to the NIH registry data from mortality. And here is their protocol. So they started with first-line treatment with bosentan, and they assessed their goals. And these are the goals that they selected, and the goals came from observations from the different studies that we looked at. They looked into 6-minute walk, they looked into some VO2 consumption, they looked into some hemodynamic data, and they looked into BNP, and they said if the patient is meeting target, and always the target is having a very good number supportive of better survival, we will stick to the same regimen. If not, we will start adding therapies, and this is their protocol. They use bosentan, then sildenafil, then inhaled iloprost, and then transition to intravenous therapy. And of course, later on, they will have to push the patient or refer the patient for transplant. And this is their protocol that they used, and it was arbitrary. It was a small study that they looked into small number of patients, but it was probably some triggering point that was adopted by many physicians in the world. This is the American summary from Valerie McLaughlin, looking into these different 6 parameters as a target treatment goals for them. Again, the data is not very good in selecting the targets, but it's based on what was available in the literature, and that was reflected too. And this is again another review by Lou Rubin from the US, that what do you do in the escalation of the therapy, and that was the start of having the algorithm, the combination therapy as we know it today. Now, in 2015, which is the latest currently available guidelines from the ERS, or European Society for Cardiology, and the European Society of Cardiology, they looked into this, into why don't we have like a stratification of the patient risk based on the available data and the available parameters into low risk, meaning that the probability of them deteriorating within a year is less than 5%, which is something that's good when we talk about pulmonary hypertension. Intermediate risk group, when their probability of deteriorating is up to 10%, and more than 10%, they are considered at a high risk category of patients who are at more probability of deteriorating. At that time, again, it was not conducted or supported by therapy, but everybody did it on a clinical grounds. We know that this patient is sicker. Probably you refer them earlier to parenteral therapy. And it was adopted. It was nicely done, covering the clinical evaluation, the exercise capacity, and the functional, the right ventricular assessment. And if you look at the parameters, I think there's nine of them here. And you say, well, I don't do my risk assessment for the patient every clinic I see them. You might be able to do physical exam. You ask their 6-minute walk. You can get their functional class, but you're not going to do an echo probably every visit. You are not going to subject them to the CAT every visit. And the way it was proposed to be used is that in each time you see the patient, you try to assess them in these different domains. And whatever assessment that is available at the time, you allocate it with a numerical number, meaning that you still look into the things that has been done. Have you done 6-minute walk test with them? If it's more than 440, they are on the green, they are good. If it is between 165 and 440, you are going to the number 2. And if they are very low, you are going to go to number 3. So at the end of that clinic visit, you divide these numbers, you add the numbers, and you divide them by the number of parameters that were assessed. In this case, we have 1, 2, and here 2, 6, and 9. And how many parameters we assessed? We assessed about 5 parameters. So 9 over 5, that's close to 2. They are about in the intermediate risk group. This is one way to look into the risk stratification of the patient. And that was probably adopted till now. It's adopted. And it was based on expert opinion. These recommendations, although made it to the guidelines, they were not very supported or not very validated into recommendation. The class of the recommendation is one, but you see the level of the recommendation. And this is something that everybody kind of felt with it. The thing that was missing is the data. Between then and now, between 2015 or probably earlier and now, people were busy looking into what is the meaning of these data. Is this data truly reflect practice? Is it accurate data? And the chance of looking into this by one of the advantages of having registries is you can really assess the data at a larger scale, not necessarily individual data, but looking at the patients. And they subjected the data from the registries into these concepts that we mentioned because the data is available at large for the patients. The first publication was from Germany. This is the comparer result. They had 1588 patients, and the available data for these patients, they stratified the patient into the risk categories: low risk, intermediate risk, high risk, according to the available data. And they started looking at their outcome, and the registry takes many years. So they could keep collecting data over years, and it was very clearly distinct in terms of mortality or survival, that the lower risk group you are in, the more likelihood. Now, we did not look into treatment here. Nobody was mentioning what these patients were treated with, yet they were looking into their classification. And since the treatment is important, how does that alter it? This registry looked into the data after starting therapy in the first clinical visit, which is the graph on the left side. After, usually it takes a few months before the reassessment, and they looked into the data, and it was very supportive. The same thing, whether at presentation or after starting therapy, you get the risk after starting therapy by a few months, and you look into the probability of them surviving after time. So it was the mortality rate in the comparator registry was at 1 year, it was 2.8% if you are in the low risk group. So about 3 people will die out of 100 people if they were in the low risk group, 10 people will die out of 100 if they were in the intermediate risk group, and more than 20 patients will die if they are in the high risk group. And that was exactly supportive of the initial concept that the Germans came up with. One other interesting thing the German registry looked into the people who were in whatever functional class or whatever category of the risk at the diagnosis, and what happens to them after starting therapy. We all see this. You have a patient who might be functional class 3 or 4, you treat them, they come to the clinic, and they improve in their functional class. So they looked into the data after the influence of the functional class, and regardless of the functional class, it pertains. So it's not only at the time of diagnosis, it's their response. So if they improve, they were at a less favorable risk category and they improved into low risk category, they continue to do as well as the people who started with low risk category. And this is something that was very nicely put together. One more thing, they looked into it, since the parameters are large and people were complaining that these might not be very supported clinically by doing, they started looking at the impact of these risk categories or risk factors or risk tools that they use in order to come up with the risk. And they noticed that not all of them, they have the same impact. They looked into the 6-minute walk. If you see here, the hazard ratio was significantly high, functional class was high, and BNP was high. So that's where these 3 parameters, their impact in the risk stratification was high, although all of them were looked into this registry. Exactly similar design. The Swedish registry came, less number of patients, but if you look at the graphs, they are exactly the same. So this is a replication, if you wish to study, looking into the same German, what they did, and they came up with the same conclusion, that the lower the risk class the patient is in, the better survival they will have over years. The French registry came with a little bit of twist. They did about the same kind of analysis, but what they did, they start looking into the criteria that can, define the patient risk group, and they went into by the numbers. So if the patient has 4 criteria, and in the low risk group, they will have the green graph up there. So that means they are low risk, and that means they have the best survival probability over the years. And the more high risk criteria they have, the worse the outcome they will have. And the same again, looking at it at the time of the diagnosis and after the initial assessment after starting therapy. They looked into why can we, if we reanalyze the data without looking at the hemodynamics, and they went back into the 3 non-invasive categories of assessment, which is the functional class, 6-minute walk test, and BNB. And they ran the data and they looked into the cases, and the exact same thing that was shown again. If you look at the green up there, that means the people have the 3 risk categories, like the 3 parameters they were looked at. If they are in the low risk category, the patient is at low risk and the probability of survival is better. And they start looking at the other parameters as well. So the French came up with the number, and it's feeding into the same concept. This is the small twist, and it was statistically significant and was clearly looking at, again, I keep reminding people, this is not looking at what therapy they were treated with. So, I mean, this is a registry data. It gives you a very big, good picture on the trend, but it does not talk about individuals. What the French group did in order to overcome this difficulty, the available data from the Griffon, which is one of the largest PH study, clinical trials that was done, they had plenty of data, plenty of patients, and they start categorizing the patient into the risk group. And this is after, of course, the study was over, and they went back and they looked into the patients and they stratified them according to the 3 criteria from, for each risk. And it was even in the group that were on treatment with Selexibag. Now this Selexibag plus whatever background they were on, and this is the placebo. It's not completely placebo. It's whatever therapy they were getting at the time of entry into the study, and they followed them for, like in this study, for 2 years. And they noticed exactly the same. The people who have higher criteria or higher number of criteria in the low risk category, they tend to do better even when they are on therapy. Was interesting enough to just confirm the concept by a prospectively collected data on a group of patients. Now we're talking about therapy. Again, showing the low risk categories, if you want to leave the number of criteria back into the traditional way of looking at the data, low risk, intermediate risk, and high risk, and they showed exactly the same clear distinction in the Kaplan-Meier graphs about mortality, and it's just a proof of concept. Now, again, they had the chance to look into what happened to these patients, risk groups between initial part of the therapy or the study and after prospectively looking at the data. And you notice the patients who were on the therapy, they improved their risk category because of the therapy, which is again supportive of the concept of having risk stratification impact into the data. So, irrespective of the risk group allocation, patients with higher proportion of low risk variables, they have, on diagnosis or at follow-up, they have lower mortality, which is probably the most meaningful thing in our medicine practice. We are trying to make people live longer or, just decrease their risk of having worse outcome. These findings strongly support targeting low risk profile. Target is that the lower the risk profile you have, the better outcome you have. This is, I'm not sure if this will fly, but that was proposed by the 6th World Symposium on Pulmonary Hypertension to make the longer list of criteria easier, taking into account what we mentioned, the functional class, the 6-minute walk, the BMP, and they kept some of the invasive or some of the hemodynamic parameters, if it is done, to be included in the risk category. And they proposed about the same number of the classification that they had, and they looked into the number of the criteria. If you have at least low risk criteria, that puts the patient at low risk group. If they have at least 2 high risk criteria, they are at the higher risk group. And of course, whatever is in between is considered in the intermediate risk group. For sake of completion and for sake of being objective, this was proposed. People objected on it because the data is still not supportive of 100%, meaning it was not looked into individual cases. And there was another risk category that is being done, which is the Reveal Registry. This is the American registry that they were not following the same conceptology as the other registries did. They were having their own assessment. It might be a little bit more complicated. They were looking into the demographics. They were looking at the comorbidities. They're looking at the functional group, even the type of pulmonary hypertension the patient has. And they looked into if they have recent hospitalizations. It's very comprehensive Reveal risk assessment score. And it was validated before. This was published probably in 2012. And there's a newer publication looking into, they modified the Reveal risk score too, they call it, showing that it might be reflective of the outcome. And I'll show you the data that was published in 2019, more comprehensive. It includes what was included in the ESC proposed risk categories, and they notice the same. Now, the difference is that this is more comprehensive, and we are talking about risk scores. Each patient, according to these numbers, will be assigned a risk score, and there's risk scores between 0 to 6, a score of 7, 8, 9, 10, and more than 13. And if you look at it, there's a clear distinction between these different colors. The higher the score of the patient, the worse the outcome the patient is expected to have. And they looked at data over 60 months, which is 5 years. So this is a very good data, very clear, and probably some people tend to look at it into a more comprehensive way. They again re-looked into the data, trying to make it simplified, and they analyzed the low risk being between 0 and 6, the intermediate risk between, I think, 7 and 9 and above 9 or above 10 is considered high risk category. And roughly speaking, it looks into probably the same. What was advantageous in this registry is that the intermediate risk group, which is usually the largest group among all these registries, might have more distinction about a proper assessment of their risk category than just looping them all together in one risk category. And that's something, of course, will add into the complexity. But for all sake of fairness, I think this has its, its way to look into it, and if the data is available. Complicated, people say, oh, how are we going to do this? Now, today, there is available Reveal 2 risk score assessment in the application or mid calculation. And all what you need to do, you enter the data, and it will give you different risk scores by just putting the patient and taking into account the pH, the comorbidities, what type of pH the patient is having. And it will give you a risk category that will give you a probability of survival. And it's very clear. This is taken from the application itself. If the patient is, let's say, at 8 points in risk in the Reveal risk score, they have an average risk, and the predicted 1-year survival is 90 to 95. It has been there for a while, and it's very well validated tool to look into outcome. So evaluation of severity is important. It has to be undertaken at each time we see the patient, and of course at the time of the diagnosis, and each time we encounter the patient. And every time you assess your patient in the clinic, ask these questions. Is there any evidence of deterioration? Is the deterioration caused by progression of their pH or by a concomitant illness? Is the right ventricular function is stable or sufficient to keep up with good symptomatology? And the current status, is it compatible with long-term prognosis? Meaning, is the patient in the favorable risk category? Because this will eventually be reflective into your action. Low risk group is something that we are trying to achieve. You try to achieve low risk group and maintain the patient on low risk group as long as you can, because this is something that is supportive of longer term data. I'm not going to talk much about the treatment algorithm, but the decision to treat the patient will be depending on their risk stratification at the diagnosis and probably in their follow-up. In order to be comprehensive, this all was done in pulmonary arterial hypertension patients, meaning WHO group 1. But there is a new recent publication, 2018, looking into the risk assessment concept in patients who have medically treated thromboembolic disease or persistent pulmonary hypertension after surgical intervention. And again, they looked into the data, and they have from the German registry, the Compare registry, treatment naive patients who have been newly diagnosed with inoperable CTEPH or residual pH after PEA, and they just showing you the numbers. They have a good number of patients, and they have, of course, prospectively looked into their outcome, and they looked into their risk categorization. They categorized them into low risk and high risk. And if you notice, the low risk group, although they are a little bit older, but some of them met the low risk category. They looked into the 6-minute walk test. They looked into the cardiac index, the mean pulmonary artery pressure, and of course, they looked into the comorbidities that the patient has. And again, not surprising to see about the similar concept of if the patient is at a low risk category, they tend to do better with medical therapy for CTEPH, whether it's inoperable or residual after operation. And they looked into it, they adopted the French way of looking at things, the criteria. If the patient achieves the 3 low risk criteria, their survival, as you can see, is excellent, versus the person who does not have any low risk criteria, the survival is completely horrible. So again, this is just supportive of the same concept that we talked about. Changing the risk score with therapy is something, again, they looked at in the German data for the CTEPH, confirming exactly the same concept as shown before. This was my last slide, and I will stop here.
Thank you so much, Hussam.
Thank you, Dr.
For such a comprehensive risk stratification talk. Very, very well done. Thank you so much. And I think, if you allow me, Mustafa, I'll introduce my colleague and friend, Professor Majdi Idris. He will be talking about the treatment of pulmonary hypertension in the coming 20 minutes. Of course, you all know Majdi, but we have more than 300 participants here, so I'm sure I will have to do some introduction, Majdi. So Majdi is the founder and the ex-president of Saudi Association for Pulmonary Hypertension. He is a consultant of pulmonary in the military hospital in Riyadh. He has contributed a lot to the pulmonary hypertension field in Saudi Arabia, and he's also still an active, productive member and advisor for the SAF group. And we are looking all forward to hearing you, Majdi, for the treatment of pulmonary hypertension. Thank you. You are muted, please.
Yeah. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Abdullah, for the nice introduction. Thanks, Dr. Rifai, for the invitation. It's really a very interesting meeting with 300 audience. That's really fascinating, and that's probably indicating the interest that we have now these days in Saudi Arabia for this disease between the clinician. So this is my disclaimer. There's nothing in particular to this talk. So just to wrap up where Hussam stopped, and definitely what Abdullah told us in the beginning. Now, when we start treating patients with pulmonary hypertension, we go to steps. As we heard from Abdullah, that we need first to establish the diagnosis, be sure about what class or group of pulmonary hypertension you are treating, whether you talk about group 1, 2, 3, 4, or 5. You need to evaluate the severity, as we heard from Hussam in a very elegant way, and you need to define the patient status before you start treatment. So before I start telling you about how to treat those patients, it's just like very simple question. Now, in any or really many other diseases, you have goal of therapy, which is, for example, in essential hypertension, you need to bring the pressure to a certain limit. In hypercholesterolemia, you need to get normal cholesterol or really LDL, and similarly in diabetes. Now, in the pulmonary arterial hypertension, maybe as a surprise, the goal of therapy is not to treat the pulmonary hypertension, i.e. not to drop the pressure. So that's not a target of therapy. And that's definitely showing from many, many data that if you look at the pressure itself as predicted for the outcome, it was the least compared to function class, pro-BNP, and 6-minute walk distance, and hemodynamics. So the pressure is really important for diagnosis. It's not that important to treatment. And this is what Hussam told you, that what we need to do when we treat patients is to bring them to the green zone. Now, if you look at really the treatment algorithm, this was the algorithm in 2015. The data was clearly there, and the recommendation was very clear that you need to confirm the diagnosis. You need to start the supportive care of oxygenation, influenza vaccine, rehabilitation, etc. And then you need to do the right heart cath, as we heard from Abdullah, and do what we call the acute basoreactivity testing. Now, if the patient is basoreactive, the treatment is very straightforward, which is calcium channel blockers that are used in those patients. And we have specific criteria for what we call basoreactive. That's really drop in the pressure by more than 10 to reach final pressure less than 40 without change in the cardiac output. So if you get that one, if your patient belongs to those 5% category of patients who have vasoreactivity phenotyping, then the treatment is straightforward, is long-term calcium channel blocker, and those patients, they do very, very good on that treatment with an excellent outcome. Now, if the patient is not vasoreactive, then we look at different category here. And then the category that we really look at is too many active signaling pathway that we are trying to target with therapy. As we speak now, we have 3 pathways that we are treating at the moment. Now, the first active pathway is the prostacyclin pathway, where we would like to accumulate cyclic AMP by using a prostacyclin therapy or prostacyclin basically analogs. So you were shown this by Hussam that the prostacyclin epiprostinol was basically the magic bullet in the late 90s, very early 2000s, where a major shift in our understanding to the outcome of those patients was shown in patients treated with IV epiprostinol, where you can see that the mortality was reduced by almost by half. Now, the problem with the IV prostacyclin epiprostinol is with the complexity of really delivering the drug. You need to have a catheter in for 24 hours. You need to have a pump that will supply the drug for 24-hour infusion, and you would like to adjust the dose to reach the appropriate response. Now, apart from the technicality of really the catheter and the device, the problem that if you have any interruption in delivering the medication because of the catheter failure or the pump failure, then you might have a rebound severe pulmonary hypertension in minutes or hours, and that can lead to basically aggressive mortality. So this is why we look at prostacyclin analog, for example, using a sub-Q infusion for treprostinil, and that has shown to be a very effective method. It has its own problem, mainly with the pain at the infusion site, so that needs special attention. The inhaled form of the prostacyclin, the inhaled ileoprost, and you have the oral, basically prostacyclin receptor agonist, selexipag, that can use in this category. So the first study that was published and get the FDA approval was the AIR study, where inhaled ileoprost was used in a category of patient of pulmonary hypertension. So those patients were mainly group 1 and group 4, majority were group 1. And you can see that, and the primary endpoint at that time was 6-minute walk distance. Inhaled ileoprost has led to significant improvement in the 6-minute walk distance compared to those patients on placebo that they had deterioration in their 6-minute walk distance. And based on this study, basically inhaled ileoprost was approved to the treatment of pulmonary hypertension. More recently, we have a very interesting data from the Griffin study looking for selexipag, the oral prostacyclin receptor analog agonist, that lead to a very dramatic response when we look to morbidity and mortality outcome, where there was 40% reduction in that primary endpoint by using selexipag, either on different category of severity of patient with PAH. The second group of medication that we are using are the medication that target the endothelin pathway, trying to block endothelin A and B receptors on the smooth muscle, and that really work by having the endothelin usually basically stimulated and secreted to stimulate endothelin A and B on the smooth muscle, leading to vasoconstriction and smooth muscle hypertrophy. So this drug that we are using in this category is trying to inhibit endothelin A or endothelin A and B both together. One of the major study done, the BREATHE study done on bosentan, was one of the earlier molecule that's used in this category of medication, looking at patient in PAH patient, and bosentan was used in 2 different doses, 125 and 250 milligram BID, again looking at the 6-minute walk distance, and you can see that bosentan in the 125 BID or 250 BID showed a significant improvement. Now, the approved dosing based on the efficacy and side effect that we are using currently is 125 BID. Later on study, the Seraphin study, looking at another molecule which has more potency compared to bosentan, which is called macitentan, that was again basically studied with a really primary endpoint was again looking for morbidity and mortality outcome, which was, this was multi-center double-blinded randomized control trial, phase 3 trial. There was 2 different dosing of macitentan that was used 10 milligram once daily and 3 milligram once daily. And for the sake of the approval, the 10 milligram dosing that we are using at the moment has showed 45% reduction in the primary endpoint. The third group that we are using are those medication that target the nitric oxide pathway. And we have basically two molecules that we are using at the moment. What's happening normally that based on the L-arginine and the presence of nitric oxide synthetase is converted to nitric oxide that need to work on the enzyme called soluble guanylyl cyclase to really convert GTP to the cyclic GMP, which is the active molecule that lead to vasodilatation and reduced proliferation. So basically, in order to maintain or preserve cyclic GMP in the system, there is two ways to work, either using sildenafil or tadalafil to really inhibit the enzyme that really lead to degradation of the cyclic GMP, which is the phosphodiesterase E5 inhibitors, or using a molecule that directly stimulating the soluble guanylyl cyclase enzyme to produce cyclic GMP. Now the super study was the first study looking at the sildenafil molecule at 3 different dosing, 20, 40, and 80 milligram TID, showing that sildenafil was effective in the 3 doses with the primary endpoint was to improve 6-minute walk distance. However, only 40 and particularly 80 milligram that showed maintaining bioavailability after 1 year. So now we're trying to push the dose to at least to the 40 milligram TID when we are using this medication and treating pulmonary arterial hypertension. The second study was the patent study looking at riociguat, which is the soluble guanylyl cyclase stimulator. In the patent study, looking at riociguat in titrating dose up to 2.5 milligram TID over 12 weeks in the patent 1, and you have the open label patent 2 study compared to placebo, and riociguat was very effective with the primary endpoint was maintained was 6-minute walk distance improved in this category of patient. Looking at the secondary endpoint as well, for example, for the PVR, pro-BNP function classes were all basically achieved. But as Hussam told us before, we need to treat to target. We need to use these medications in order to bring the patient into the green zone. And again, this paper was shown by Hussam, but I'm going to address it from different perspective. This is Marius Hooper's study when he came with the first idea of the goal-oriented strategy that using these drugs not to decrease the pressure per se, but to reach the target. And the target they used in their paper was they wanted the patient to be able to walk for more than 380 meters. They need to have at the peak oxygen consumption more than 10.4 ml per minute per kg and maintaining systolic pressure of more than 120. So this was their target. Not only that the patient's feeling better or they can walk longer only, they had to reach the whole basically 3. And to do that, they started only in one drug. If they reach that element, they continue on a single monotherapy. If not, they keep adding sildenafil, inhaled ileoprost, basically parenteral prostacyclin, and then lung transplantation in order to reach that target. And definitely what they found was very interesting, that this goal-oriented approach was very, very effective in improving the outcome comparing to the historical basically control group that you have patient treated with monotherapy, waiting for deterioration before adding second drug, and then waiting for deterioration before adding the third drug. So here, by avoiding that and start from the beginning, reaching goal of outcome was definitely better. However, that was recently challenged, that probably that was not even the best approach. So this was coming from the Serafin data, and the Serafin data was the first study to give some light on this, because in Serafin data, when we look at the patient who were at target, so they were actually in the green zone in one drug, and then macitentan was added, you get an extra 42% benefit in the outcome. So that tells you that maybe it's not only important to be in the green zone, but you need to be in the green zone by more than one medication to get the best effect. And that was shown again in the patent study using riociguat in those patients who were treatment naive or they were on other medication, and both showed that really, even if the patient was in the green zone, adding riociguat was really beneficial. Until the ambition study addressed that point from the beginning. So they look at patient, and from the beginning, they were randomized to monotherapy with either ambrisentan or tadalafil with placebo, or combination from both drug, ambrisentan and tadalafil, from the beginning. And what they found, very interestingly, that the really primary endpoint was very suggested that the combination therapy from the beginning was much more beneficial to the patient compared to monotherapy. And this was true even with those patients who had very mild disease or they were in the green zone at the beginning. So the two drugs of ambrisentan tadalafil was better than either one when it's used as a monotherapy. And so this is, in a way, shifting the strategy of treatment from goal-oriented to outcome-oriented. So now, yes, we want the patient to be on the green zone, but we wanted them to be on the green zone in multiple medication. And that was, in a way, reflected by the most updated guidelines based on the 6th World Congress. They are now looking at those patients who are either low or intermediate risk, so green or yellow zone, and now the recommendation is to really start initial oral combination, even in the green zone patient. However, they kept this monotherapy arm, but they made like very strict recommendation that there's very special patient who can benefit from monotherapy. The vast majority of patients should be on combination therapy. And so who are those patients who might benefit from monotherapy? Those who are, for example, vasoreactive. They can be only on calcium channel blocker unless they lose that reactivity. Those patients who've been on monotherapy for years and they've been stable, probably you can keep them like this. Those who have PVOD, or those patients who have HFpEF, so have a form of mixed pattern, if you like, between group 1 and group 2. So what we call a combined pre and post capillary. You don't want to start combination therapy in those patients. Or of course, if the combination therapy is unavailable or really contraindicated. So my take-home message to you is like this. PH patients should be managed differently in referral center. Treatment goals must be very ambitious. In PH patient, treating the pH itself, the pressure itself, is not the goal of therapy. And as we heard from Hussam, that the goal of therapy is to bring the patient to the green zone. A goal-directed approach has been considered as the standard of care for a while. However, that has recently been challenged. Vasoreactive patient can be treated with a calcium channel blocker as a monotherapy. Otherwise, patients should be on target therapy. Now we have three different basically drugs that use already three different mechanism of action drug that can be used, either prostacyclin pathway accumulating cyclic AMP, basically antagonist, antagonizing basically endothelin and blocking its receptor, and nitric oxide pathway, basically kind of augmenting cyclic GMP. However, as we said, based on the recent data, the Serafin, the patent, the Griffin, and definitely the ambition study, combination therapy is now the standard of care. And we have learned out from this major study that the combination of the ERA, PDE5, or soluble guanylate cyclase is probably going to be, or it is the case now, to be the standard of care, even in those patients who belong to the mild disease, those who are in function class 2, or they are in the green zone. These trials suggest that, as I told you before, that the concept of the goal-oriented therapy should be changed to the outcome-oriented therapy with an early combination in the majority of the PH patient. And thank you very much for your attention.
Fadal Mustafa, thank you so much, Majdi. Very comprehensive treatment talk. I think you are muted, Mustafa. By the end of this very outstanding session, I'd like to thank the speakers for their time, and it's time now to take questions. And Mustafa, please, you can lead this, but you are still muted, please.
Yeah, Mustafa,
you are muted. Unmute your mic, please. Yes.
Okay. Okay. I think we have some questions.
Let me start, if you allow me, while you're reading the questions, I will start asking Majdi. So the practice now obviously is a combination therapy, as you nicely illustrated. If you have patients who have been already on treatment and they're stable on monotherapy, I know they're very rare, but they have been stable like this, especially when it comes to congenital heart disease, cerebral hypertension. Would you add combination therapy just to prove the, the evidence-based practice, or if they are stable and they are low risk criteria, we'll just leave them alone?
Well, thank you, Abdullah. Actually, this one of the criteria that they mentioned that maybe you need to continue or you can continue on monotherapy. However, so I do have those patients. I'm sure you have, Hassan, and Mustafa, those patients who've been with us for now 7-8 years on sildenafil or bosentan. And they are doing very, very well. They are a function class 2, their proBNP is normal, and they are idiopathic PH, and not even congenital. However, at the beginning, to be honest, I was keeping them on sildenafil alone. But recently, I start adding another drug. And now, this is probably not in particularly kind of tested in the clinical trials, but based on the ambition trials and the others, we might be doing something for those on the long run. We don't know. But to be honest, this is now my practice. I'm trying to add, at the moment now, we really, in basically our hospital, we have macitentan. So we're adding macitentan to sildenafil or to tadalafil. So most of our patients now are on macitentan and tadalafil. I don't recall that they have anybody on monotherapy at the moment.
Yeah, there is questions for COVID, why it was kept in group 1, why they are keeping BVOD in group 1 in pulmonary hypertension classification.
I think this question is to me, yes. Well, BVOD, as you know, is it's now considered as it's not only the BVOD that is the inherited disease, it's actually idiopathic pulmonary arterial hypertension patient who has an overt involvement of the venous system, either because of the continuous inflammatory / histopathological changes of the idiopathic or any other form of PAH, or it's actually genetically inherited, like the BVOD itself. So that's why it's actually kept in the PAH group, but they have been given this standalone number. So it's a pulmonary arterial hypertension with overt venous involvement, whether it's a BVOD itself or not a genetically inherited disease, which we see now, and I'm sure my colleagues also can agree. We see now advanced idiopathic pulmonary arterial hypertension patients who are not genetically inherited a BVOD, but still yet they have features suggestive of venous involvement.
Abdullah, can I ask you a question? I know we are rewriting the guidelines. Actually, that's a very interesting question, because now the PVD is always really kind of bothered me to leave it in group 1. This entity, even histopathologically, the disease is mainly, not necessarily all, basically exclusively, but really mainly similar to group 2, which is in the venous side. The treatment is more towards group 2 disease, which is aggressive diuretics. Yes, we can use some low dose target therapy, but the treatment is mainly diuretics in those patients. So in a disease which histopathologically is closer to group 2, which is in the venous side, really in the post-capillary level, although the wedge is still normal, but it is in the post-capillary level, the treatment is closer to group 2. Why it is still in group 1? So why?
I'll tell you the simple answer, Dr. Majdi. They are not actually similar to group 2 in any form, except for the fact that they are actually having some post-capillary changes, which is in the venous system.
Right.
However, everything else is different. I mean, they have a pre-capillary component of the pulmonary hypertension that is having changes you see in the pulmonary arterial hypertension. You see the cytothrombosis, you see in this patient the medial hypertrophy, the intimal fibrosis, you see plexiform changes, you see, and hemodynamically the same. It's a high PVR, high mean, high, and normal wedge. The only different feature of this group from the PA, the idiopathic, the fact that they have involvement in the venous system at the histopathological level, which also you don't see in group 2. So if you have a group, isolated group 2, post-capillary group 2, and I know you know this, Majdi, I just want to, because you have many audience. If you have an isolated group 2, basically you don't have any histopathological changes. You only have a reactive high pulmonary artery pressure with normal pulmonary vasculature and high wedge pressure, and no venous system, no arterial system histopathological changes. Obviously, this is the pure isolated group 2 pulmonary arterial hypertension. Obviously, it's not the case all the time, because you can have also reactive form where you have histopathological changes. And I think this is where your question coming from. Yeah. When you have this combined form of pulmonary hypertension. But this takes us to the dilemma that is, when you have a group 2 pulmonary arterial hypertension, pulmonary hypertension, and you have very high PVR also with this, is it a PAH group and the patient developed later on a LV problem, or it's an extraordinary reaction to the LV problem? So this is where the dilemma comes from. I understand your question.
Yeah, if I may add, and I think I agree with Majdi that this is a completely different entity. The problem is, how are you going to detect it? Majority of the cases has been come into clinical attention after the fact that they were treated as PAH patients, which is the regular patients that we see. The age group, the clinical presentation, the hemodynamic, and of course, they will fail the therapy part when they start having pulmonary edema. The detection of the genetic association in the idiopathic form, I think it was published in 2014-15. So it's still young, and the number of the families they were actually detected was not huge. There were small number. It's a French study, and with time, I think if we have enough pre-clinical or pre-therapy course features, probably that will be moved away into a specific category they have. It's just a matter of keep them in mind, and but they are completely different disease entity, and we see them now. I'm working up one person, young patient, who I'm highly suspecting clinically. I'm cautiously treating her, and actually I will be referring her for transplant. Although the confirmation of the test is not the greatest, and I'm not sure even if her genetic test will come back to be positive. But I'm having that feel about this being a PVOD, and the outcome, the end outcome, which is the transplant, if you wish, from this treatment perspective, is going to be the same as severe PAH anyway.
Yeah, there is another question. There is a lot of risk stratification method, like the Reveal Registry or the ERS guideline available. What we will do if difference in risk stratification given by two different methods?
Sure. These two different, you're right, thank you for the question. These two different methods, they are not contradicting each other. They are just choosing different approach, different input values in order to be accounted for in the risk group. If we are practicing in the US or the US based doctors, if you wish, they are still having a very strong feel about the Reveal. Things has been made very easy for them, and that's what they go with because it's really kind of their invention. Now, if it's make it to the guidelines, they probably will have a hybrid, or they might propose both. Even if they propose the ERS approach, the Gallier probably approach, the one that he's advocating, still we can use it. I mean, we're not saying this one is better than the other. It's beyond probably the scope of this lecture to talk about the details between it. As long as you are keeping the idea of risk stratification in mind, whichever you want to use, and you are taking action, assessing it frequently, and taking action according to the risk stratification in terms of treatment escalation, referral escalation, I think the mission will be fulfilled. So whatever you feel more comfortable with, whatever that suits your practice better. Some people, they like to use gadgets and they they like to use the mid-calc, and some people, and trust me, with time, you will be stratifying your patient with a little bit of more practice without even going back into checking the numbers, but it will have some scientific background to support your decision for later on. Nobody is going to take major decisions based on one parameter. It's a collective clinical picture with a little bit of hemodynamic picture and some simple data by echo and the blood testing. Hopefully that answers your question.
There is one request. Thank you for this webinar. Is it possible to have the slides sent to our email? Probably this will be forward to Kunuz Ritaz. This is request from one of the questions here.
We still have about 9 minutes for discussion, so I really encourage our colleagues who are joining us from everywhere, and use this time and please ask questions. For the time being, also ask my colleagues questions. Now, the practice here is different from the actual from the guidelines. So real life practice is normally different, and in our culture too, the activities of subcutaneous or IV prostacyclin is not being the best. Maybe we noticed that maybe the last 1 or 2 years things are changing. So, so what's the position of prostacyclin analog receptor agonist? Sorry, Majdi and Sam, in your centers. Well, when do you think it started, and what's your experience so far with it?
Okay, so I can tell you that basically at the moment we're using selexipag as the third drug. So we're using basically PDE5 inhibitor / riociguat plus macitentan very, very early. Selexipag so far is being used as the third basically option in those patients who are not controlled on the first two drugs. However, I think the main reason we're doing that at the moment is the cost. The drug is very costly. It is still a little bit more complex than using a selexipag than a macitentan or sildenafil or tadalafil. It's probably as complex as riociguat because you need to titrate the dose. So this is why, at least in my practice, I prefer to start with macitentan and tadalafil. However, I'm sure that the studies are coming when you start using basically more aggressive approach and start using 3 drugs. Now we have the Triton study basically looked at it. So maybe we're gonna have a time coming that we can use really the 3 drugs, or if you have studied to say that the prostacyclin pathway is very specific, so start with that pathway before the other 2. So, but to my knowledge, that this data is not yet available.
Sam, if you wanna.
Yeah, I think there is a question here. Patient with mitral valve regurg and stenosis, PA pressure 70 millimeter of mercury, atrial fibrillation on anticoagulation, cough. What is the best management for this patient? Is the best doctors to treat this patient is the cardiologist or the chest physician? Probably I will answer these questions because this is our bread and butter daily.
Yeah, so we're gonna basically disagree with you later on, but that's fine. Go ahead.
It's okay. Go ahead. I mean, every day we have patients with severe mitral regurg, with severe pulmonary hypertension, atrial fibrillation, or severe mitral stenosis with a PA pressure maybe 100 or 110, and definitely initially you treat them for left heart disease with diuretics, with the usual treatment for severe heart failure, but the ultimate treatment is surgery. If there is obstruction in the mitral valve, treatment will improve symptoms, will improve pulmonary edema, will control AF, but you need to replace the mitral valve by mechanical, by tissue, by repair. You have to solve this mechanical problem. The same for mitral regurg. We have patients with severe MR, severe pulmonary hypertension, and when we do surgery, when we correct the mitral valve problems, PA pressure go down, everything improve. So this is probably the short. I know Majdi will partially not agree.
No, not necessarily, actually.
No, I totally agree. Actually, but I need just to add one thing, because at least in my hospital, our cardiac surgeon used to use a lot of sildenafil in those patients.
In ICU, sometimes, yeah.
Yeah, and we keep disagreeing with them. And now there is basically a study to show that sildenafil in this category of patients increase mortality. So really now the idea is very clear. The message is very clear. Those patients should be treated surgically. Treat the mitral valve. Of course, we do understand that the presence of pulmonary hypertension increase the post-operative really complication in those patients. They might need some more ICU, basic admission, some anatropes, etc. But yes, I think I totally agree with you. The treatment is not to touch the pre-capillary really component in those patients, but treat the mitral valve itself. Hussam, Abdullah, I'm not sure.
No, I just wanted to add one thing. I mean, the question is vague, and I'm sure this is based on an echo rather than a full hemodynamic set. So characterizing the patient with a very good diagnostic, workup to identify the different components of the pH is important, as Abdullah mentioned. And the other part is, you don't have to really reinvent any wheels. Yes, that might be a clinical dilemma or fight or referral back and forth between pulmonary and cardiology about these cases. But it is what it is, just don't harm the patient by giving them something that they don't benefit from. The better characterization of the patient is the way to take it from there.
Yes. Dr. Hisham Hussein, yes.
Thanks for the great talks. Just I want to pose a question here regarding the intervention. The balloon pulmonary angioplasty for patients in group 4. Do we have a local data in comparison to international data? And what is the success rate in that category of patients?
We don't have the local data. We have one case done already. I'm not sure if other hospitals did, and really our hospital. So definitely nothing to compare with the international data, but this is where it's going. And I think now the more cardiologists I was talking with Tarek Kashour the other day, and they were thinking to start this program in the university. I'm sure King Faisal, King Fahad, everywhere where you have very competent cardiologists. However, the problem here is not to really stick the balloon in. This is not like basically stick the balloon and really basically you need to understand the pathophysiology of the disease, the type of the obstruction, the size of the obstruction, the post-obstruction pressure and the pre-obstructive pressure. So that all should be really calculated, which vessel to target first. So this is need to build an expertise, local expertise, before we have a very valid program. So your point is very well taken, that need to be built up, that kind of experience. I think the easiest way is basically to stick the balloon and really to inflate the vessel, but it's not that simple, unfortunately.
You have to calculate the result. Yeah.
It's maybe we at SAF, maybe we need to take this more seriously and focus on one center only. So actually, the expertise cannot be acquired if every center does 1 or 2 or 3 cases per year. So maybe this is something we need to discuss. I'd like to go back a bit to that simple, straightforward question: which doctor will take care of that patient with mitral regurgitation? I know it's a very simple question, and I'm not talking about medical net. It has been already tackled by Majdi and Shabab. Complex cases of pulmonary hypertension should be dealt with in multidisciplinary approach. I would not say a patient will be taken care of by cardiologists or by pulmonologists or by are the cases which need basically people to get together, cardiologists with experience with pulmonary hypertension and hypertension physician from the pulmonary hypertension side, pulmonary medicine side, radiologists, pathologists, everybody else. So for my colleagues who are listening to us now, real things for treating complex patients normally harmful. So I would really recommend and suggest highly that these patients be treated by multidisciplinary meetings, approach, which requires normally meetings after meetings. reach a consensus way of taking care of it.
And if I can basically add, now we have the SAF basically PH Club. So please, if you have interesting cases, come and join really us with that, discuss with us so we can learn from each other. So anyone has very interesting cases, so please kind of approach SAF and we can have that case discussed in the SAF PH Club. So we all learn from each other for sure.
There is one question here. Which route is the best for prostacyclin analog? To use sub-Q, oral, or IV?
You want me to take this? Or,
yes.
Okay.
Go ahead.
So I will ask Raji later on to conclude this. But from our experience here, we can divide this question into two things. One is, what is the most definitive treatment, the best way of treating these patients when they are, in a functional class that requires a prostacyclin analog is IV, no doubt. But IV route has also its own complications. Majority of our patients prefer subcutaneous route. And it has also its own negative things. Now, for IV route, which is the more definitive one, no pain, no local treatment. 85% of patients with subcutaneous infusion, they have severe pain sometimes. But it needs medication and very sterile technique when you actually mix your medication in the pump. Because basically it's going into this central cardiovascular system. So any patient who does not do it right, not committed, level of education is not high, does not have social support, it's quite dangerous too. Because we lost one patient with gram-negative sepsis about a few years ago. The subcutaneous route, although it should be done in a clean way, but not necessarily, a sterile way, but it has also its own problems. I mean, the pain is normally very bad, and patients require for the first 5 days or so strong painkillers. So the short answer to the question, IV is the best. Subcutaneous is still considered systemic treatment, which is still, of course, fine. We prefer IV, but our majority of our patients prefer subcutaneous because of, it's smaller palm, they just can wear their dresses and nobody can see it and all these things. So I don't know if Majdi, because he has the two therapeutic.
Well, I totally agree, Abdullah. I think the data is more conclusive on the IV therapy. We have lower number of studies done on the sub-Q. So if you'd like to have the scientific evidence, it's going with the IV epoprostenol. That's the gold standard medication that's been used. As Abdullah said, the technicality and the logistic of using that drug within our system is a little bit complex. When we started our PH program, we used to use IV epoprostenol only inpatient to basically rescue the patient, to basically stabilize them. And then we used to basically discharge them on the oral therapy, combination oral therapy. Because most of our patients, they were coming from basically villages away from Riyadh. So the technicality was not very good. Having said that, I would like to ask my colleague, because in the last few years, with the availability of the multiple oral medication, these drugs are becoming really, really effective, and really the need of IV epoprostenol or sub-Q even. So I remember that in the last year, we have only one patient require sub-Q, but really everybody is getting reasonable control, quite a good control on combination oral therapy. So if this is what everyone is experiencing as well, Hussam, Abdullah?
Yeah, but I'll answer you, Majdi, but let me get back into the original question. Of course, different medications, they have different things, meaning that not all the prostanoid can be used sub-Q or IV. This is one important aspect. The medicine itself, which is the epoprostenol, it cannot be used except IV, and this is probably the drug that nobody disagrees. It's the prototype, it's the thing that everybody talks about. Now, the other drug can be used in IV form and sub-Q form. There is still some people question the efficacy, and probably I use both it's a little bit less efficacious than the epoprostenol. Yet, if the patient can tolerate sub-Q, it's a convenience thing, although it's truly not convenient. Yani people will have a lot of local side effects and pain issues that sometimes is counter in, productive, and people will eventually ask to be taken out of it. There is no oral prostanoid. What is oral available is the prostacyclin analog. The other oral prostanoid is not approved. It's not available in the kingdom, which is Paraprost. Nobody uses it except Japanese. I think Majdi used it a couple of times. I used it before in the States, and it did not fly. So that's an agent that nobody is, let's say, generally speaking, is not using. Japanese use it because it's locally made, and they have their own data that we never see because it's published in Japanese language. Getting back into the effectiveness of the oral therapies, now we do see some effectiveness combined with early detection, but that does not prevent some patients requiring intravenous therapy at one point or another in their practice. Now, unfortunately, because of the current environment, we are used to seeing people crashing and really getting into real bad shape before we sometimes intervene with IV therapy, or they come to the ICU, and that's something that is not being practiced in the West. So they don't wait until the patient gets into that phase. Yes, oral therapy is effective, and the more you see patients, the more you realize that you cannot live without having an IV therapy. And now it's very nicely comprehensive. We lived in the era where the only thing available is IV therapy. Oral therapy became available, less and less IV therapy is being used, but they are complementary, I would say. If you truly have a PAH patient, very rare that you will see this stabilizing over many years. Majority of them, they will continue to deteriorate, maybe stabilize a little bit, not like before, they come and they die within 5 years or 3 years, but you can extend that, but eventually they progress to the point where either they will require transplant and or they will just unfortunately have severe illness and they die. So the need is there. The number of patients will continue to increase. I don't know what happens to them. Some of them, they really die. But the concept of combination therapy, whether double or triple, definitely has supported the hemodynamics, the remodeling of the right ventricle to the point where it is somewhat, I think it's effective better than before. Now, if you look into the worst cases of PH, which is the heritable form, most of these patients, they go into IV therapy earlier. We don't see much of these in our genetic pool, let's say, very few of them. And if they are either missed, not diagnosed, they are still in the early phases of therapy yet, or they die without even us knowing about them.
I think we have a lot of questions here going. Maybe we can take the last questions and then we get a break. The question is for the cardiologist. Can pulmonary hypertension lead to left-sided heart failure rather than the opposite?
You are the cardiologist. You answer this. Or I don't know if Hussein is cardiologist.
I think both are neighbors. The interventricular septum is in the middle between the LV and in the RV. And it contributes to the ejection fraction of both the LV and RV. In all types of pulmonary hypertension, you will see the septum shift to the left. So it will make the left ventricle small. So it will reduce the stroke volume. It will reduce the cardiac output. Okay. And when the right ventricular advance, it become bigger than the LV. So it will be on the expense of the LV. And also the septum become more fibrosis. If it's not treated, if we don't try to reverse the pathophysiology, so you end with fibrosis of the interventricular septum, which is an important component for the LV function to generate ejection fraction. I think the answer is yes. Maybe initially, the LV function has to compensate for the problem, like the right. When the LV function initially deteriorate, we found the RV function try to compensate. But when it gets fatigued, at the end, both of them, they will go down. I think this is what we...
Mustafa, may I add here, diastolic dysfunction that happens to the left ventricle might be responsible for the dyspnea that the patient comes with, and some of them comes into pulmonary edema, even
Group
though
2.
they have congestive heart failure.
Yeah, group 2, yes.
Yeah.
I may add from ICU experience, the majority of the times, the patients with right ventricular failure, if they are very advanced, it can actually lead to diastolic dysfunction. And this is how they run into more serious complications because of the ballooning of the right side, pushing it towards the left, and impingement of the, the venous return, let's say, or the, to the cardiac function. One more thing that sometimes the right ventricle has been reported in many case reports, that the pressure on the right ventricle, sometimes it will impede the coronary circulation. And there are some case reports that where a stent had to be put to protect the left side from having ischemia. So yes, it is not direct relationship, but it is definitely, as Dr. Mustafa said, they are close to each other, and sometimes one pressure will push into the other, causing it to fail. But the probably easier answer is no, you don't see left heart failure from right heart failure in the sense that the patient will come with pulmonary edema. It is a little bit more complex than that. This is probably pre-mortem. So if you ever see pulmonary edema, they probably less likely to be a PAH causing pulmonary edema. It's the other way around.
Thank you, Hussam. I just wanted to say that, but you already said that. You really have to be careful saying that pulmonary hypertension can cause left heart failure. Of course, if the patient has metabolic illnesses, diabetes, hypertension, and older people, and all these things, they could develop
both.
Yes, but to see a pure pulmonary hypertension causing left heart failure, we have to be careful from this, because I don't want people now, from the 300 people here, if they are seeing a pulmonary congestion, pulmonary edema, and they are originally having pulmonary hypertension, they should look for a new event in this patient causing the LV problem, not the pulmonary hypertension.
And
I think Abdullah,
allow me just to say one word, because I totally agree with Abdullah, Hussam, and everyone. You do not get frank pulmonary edema with PH. However, some of those patients, when you do a right heart cath, you might get a wedge of 15 or 16, and that's because of, really, as you said, that the left ventricle is basically compressed. And once you treat the pulmonary arterial hypertension, the wedge goes down. So you have to be careful when you have in those patients a wedge of 15 or 16 or 17 to call them as a group 2. They could still be group 1. So you need to look at the clinical phenotyping. And there was initial studies done really at animals that when you open the pericardium to those patients, the cardiac output improves significantly, because now the pericardium is really containing both ventricles. And there was very interesting animal studies very, very early trying to how you overcome this really compromise of the left ventricle is just by to really open the pericardium open, and then it gets significant improvement in the cardiac output. But again, that really emphasized that the left ventricle has been under basically circulated because of this low cardiac output from the right ventricle.
I think, Mustafa, we should stop here because we're yes, and prior time. Go ahead, please, and conclude, Dr. Mustafa.
Yeah, I want to thank all the speakers, attendee for excellent session. I think for the sake of time, we have to resume back for the second session.
I think you have to give a time because we're already over above the time now. I think 15 minutes for Maghrib prayer and everything. 15 minutes would be great. So people should be back. It's
10 minutes. Yeah. So we have to be 5:40. So that will be 10 minutes. 10 minutes, huh?
Okay.
Okay. Thank you.
Thank you so much, guys.
Sorry, it's 5:35 now, yeah, Mustafa. So I think 5:50 is good. So people can. 5:50.
Okay.
Okay. Thank you so much.
Thank you so much. Have a good one.
You too. Bye-bye.
مساء الخير، السلام عليكم.
عليكم السلام ورحمة الله
شباب
وبركاته.
ان شاء الله طيبين. فرصة سعيدة الاجتماع بالمؤتمر.
الله يسلمك يا دكتور.
حياكم الله.
And I'm hearing Dr. Mustafa, and I think we can start. هو دكتور عبد الله عنده مشكلة في الصوت، أنا مش عارف. دكتور مصطفى, I think we are hearing Dr. Mustafa.
أنا أتوقع it's time to start. Go ahead يا عبد. I'll present you.
Okay.
إذا عبد الله ما قدر يبعد. السلام عليكم ورحمة الله وبركاته. حياكم الله ومرحبا بكم جميعا. It's my pleasure to present Dr. Mustafa Rifai, consultant pediatric cardiologist, Saudi Al-Batain Cardiac Center. He's known in the pulmonary hypertension field, and he has a huge experience. And we most welcome to give us one of his experience in echo and BH. Welcome, Dr. Mustafa.
Shukran, Dr. Omar. Thank you very much. I want to thank Dr. Abdullah Da'an and the SAB for giving us the chance to have this joint session between Saudi Al-Batain Cardiac Center and Saudi Society of Pulmonary Hypertension. So I will talk about echo in pulmonary hypertension. So pulmonary hypertension divided by Doppler echo, a mean pulmonary artery pressure of 20. Previously it was 25, but the last Congress it was dropped from 25 to 20 millimeter of mercury by modified Bernoulli equation using the TR velocity, whereas the V indicate TR peak velocity. If it is more than 2.8 meter per second, add to it the right atrial pressure more than 5, so total will be 31. But this is from the Doppler. But we have to remember that right heart cath remains the gold standard for the diagnosis of pulmonary hypertension. Transthoracic echo, and in selected cases, we may use TEE for the detection and assessment of severity, etiology, impact on RV structure and function, and response to therapy of pulmonary hypertension. So we have to use all the modality of echo. We have to use the M-mode, 2D, color, Doppler, pulse Doppler, continuous wave Doppler, and now recently start using 3D echo for assessment of the morphology of the right ventricle. So in transthoracic, we use left parasternal long axis, short axis, apical fourth chamber, subcostal long axis, and short axis. We have to detect RV pressure overload or volume overload by looking into the septum. If the septum shifts to the LV during systole, this is a pressure. If during diastole, this is volume overload like shunt. So we have to look into the thickness of the free wall. If it is more than 5 millimeter, this is RVH. And we have to measure the dimension of the RV in diastole at the base 42, at the mid 36, and the length 86. And we have to get the right ventricular ejection fraction normally more than 40%. We have to check the TAPC around 2. And we do the TAPC usually in the fourth chamber using the M mode of the lateral wall. If the TAPC is less than 1.6, this indicates RV systolic dysfunction. Now currently we're using our real-time 3D echo to assess the RV ejection fraction. We have to do certain measurement in the for RA and for RV, and we have to measure the IVC and collapsibility with inspiration and with sniffing. Usually if the IVC more than 2, so indicate in the RA pressure more than 10. So this is summary of the Doppler. For PA systolic pressure, if we use the TR signal, so 4 multiplied V2 square plus right atrial pressure, this will give us the PA systolic or RV systolic pressure. So the mean PA pressure, we get it from the early PR velocity plus the right atrial pressure. And pulmonary vascular resistance, if it is more than 2 Wood unit, indicate pulmonary hypertension. So this is the hemodynamic we get by echo in the echo lab. If we have elevated mean right atrial pressure, usually the IVC more than 2.1 centimeter, and it will be reduced less than 50%. And there will be prominent diastolic flow reversal in the hepatic vein and SVC. Systolic pulmonary artery pressure 4 multiplied multiplied by the TR velocity in square, plus right atrial pressure. For diastolic PA pressure, we use the end diastolic pressure multiplied by 4 square, plus the right atrial pressure. The mean PA pressure, we use the end diastolic PA pressure. I will show it in tracing. So we can calculate also the pulmonary vascular resistance. So how can we calculate pulmonary vascular resistance in Doppler? Simply, we measure the PA systolic pressure divided by RVOT VTI from the pulse Doppler across the pulmonary, across the RVOT, plus 3 if there is notch. We have to also measure the myocardial performance index by measuring the isovolumic contraction time plus isovolumic relaxation time divided by systolic ejection time of the pulmonary artery. Again, as I said, we have to measure TAPC, and we have to measure the fractional area change. So this is pulse Doppler across the pulmonary artery. We measure the pulmonary acceleration severe the pulmonary artery pressure. Here you can see the notch here indicates severe pulmonary hypertension. Here we measure the TAPC. We put the M mode here across the lateral wall of the RV free wall, and this is the measurement of the TAPC. So this is pulmonary regurg signal. So we have to measure in 0.1 and 0.2 to get the mean and the diastolic PA pressure using Doppler. Okay, this is a TR signal. You can see the velocity here almost closer to 5. So the computer, if you trace it, we will give us the RV systolic pressure, which in this patient around 72 plus, if you add 10, this 82. So the RV systolic pressure is 82, indicate from the Doppler, this is severe pulmonary hypertension. So this formula from the Mayo Clinic, they are putting it in the echo lab for the technician. They have to put all these calculations, and really it's not difficult. Okay, so you have to also do, as we do for the left side, we have to assess the RV diastolic dysfunction by getting the E and A ratio, and see also the deceleration to tell you, is it abnormal relaxation or restrictive with high right ventricular end diastolic pressure. We use now tissue Doppler. We use the S wave. If it is less than 10 centimeters per second, indicate reduced RV systolic function. And myocardial performance index, if it is more than 4, indicate systolic dysfunction. This is simple Doppler. So about the pulmonary artery pressure, if it is from 25 to 45, this peak. This is mild pulmonary hypertension. If it is from 46 to 65, this is moderate. If more than 65, this is severe pulmonary hypertension. So I will give you some interesting cases we have seen in our center. This is a 24 years old female presented with dyspnea class 3 to 4, fatigue. She was college student. She was not able to go to her college. And physical exam, she has raised JVB, loud B2, systolic murmur of tricuspid regurg, right ventricular heave, and X-ray, she has cardiomegaly, mainly right ventricular enlargement. So here you can see there is mild pericardial effusion, and this is a bad sign in pulmonary hypertension. You can see the right ventricle is small because the interventricular septum is shifted to the left, and you can see the right ventricle is dilated. Okay, this is RV inflow, where you can see large right atrium and large right ventricle. This is pulmonary artery dilated. The pulmonary artery is almost twice the aorta, The branches of the pulmonary artery is bigger than the aorta, indicate this is severe pulmonary hypertension. There is also pulmonary regurg. You can see this is a short axis at the LV. You can see normally the LV is bigger than the RV, but in this patient, the RV is almost twice the LV, and you can see the D-shaped. This is a sign that the pressure in the right ventricle is more than the pressure in the left ventricle. Okay, this is a 4-chamber view. This is very important. Normally, the septum, the interventricular septum is in the midline. It is not shift to the left or not shift to the right. But here clearly, you can see the right atrium is bigger than the left atrium, and the RV is bigger than the LV, and the interventricular septum is shift to the left, indicate this patient has severe pulmonary hypertension. Again, another sign, severe tricuspid regurg with dilatation of the annulus, severe TR. See the IVC dilated with partial collapsibility, with hepatic reversal. This is the M mode. Again, you can see the RV bigger than the LV, and the septum is bowing toward the LV during systole, indicate pressure overload from the RV. We have to do the measurement, ejection fraction of the left. Okay, now here you can see the TR velocity. We usually get the maximum one, and the maximum here we get different one. We get 89, 74, 68. So usually we get the maximum, which is 89. And even this, still we are underestimating. Whatever we are good, still we are underestimating. So here the RV systolic pressure is almost more than 100. So it categorizes severe pulmonary hypertension. This is hepatic reversal. This is a second case. This is another case, young patient with severe pulmonary hypertension. This is probably worse than the first case. You can see the RV is huge, the LV is very small, and the interventricular septum is shift markedly to the left. See the pulmonary artery dilated. See here, this is a 4-chamber, huge right atrium, huge RV with markedly reduced RV systolic function. You can see the LV is very small. I bet you the LV function is also reduced in this patient because of significant dilatation of the RV and significant bowing of the septum to the LV and very small LV. There is severe tricuspid regurg. Again, here you can see the notch. You can see the short acceleration time. You can see the PA pressure, continuous wave Doppler, so we can get the mean and the diastolic pressure from the continuous Doppler of the pulmonary. This is the TR here, 84 plus 20, so almost above 100, the RV systolic pressure. This is a third case, which is left heart. This is a young patient who underwent, he had mitral regurg, so he underwent mitral repair, but he ended up with severe pulmonary hypertension secondary to mitral valve disease. So you can see the septum is shift to the left. Okay, this is here the tricuspid. You'll see severe tricuspid regurg, free TR, dilated pulmonary artery. You see the D shape of the interventricular septum. You see the fish mouth appearance of the mitral stenosis. See the D shape of the interventricular septum, severe TR. Okay, this is 4-chamber. We can see this is post-mitral repair, severe TR, dilated RV, severe tricuspid regurg, and severe pulmonary hypertension. You see IVC dilated and non-collapsing, indicate this patient has severe pulmonary hypertension. So the mitral valve area, 1.6, IVC almost 2.8, pulmonary artery markedly dilated. This is case 4. I think this is a young patient came with pulmonary embolism, and this is the first echo, dilated RV, and you can see the TR, moderate TR, D-shape, indicate pressure overload, huge right atrium, huge RV, TR, IVC dilated, non-collapsing, and you can see the PA pressure here, 70. If you add 10 to 15, you can get an RV pressure of 90. So this patient, okay, this is the patient. So this is the patient with pulmonary embolism, treated with anticoagulation, with heparin, with warfarin. Initially, the PA pressure was 65. This is before treatment. You can see the notch here. And this is at follow-up. You see the LV function, the RV function improve. The TR getting mild after treatment with only heparin and warfarin. This is after 6 months of treatment. You can see the LV now round. And you can see now the septum in the middle, TR mild, and you will see the PA pressure reduce almost to half. The maximum gradient here, 16. So the last case, this is a 30 years old female patient diagnosed to have mixed connective tissue disease. She came for the first time with severe pulmonary hypertension. She was not on treatment for mixed pulmonary disease or not for pulmonary hypertension. This is our first echo. You can see small LV, large RV, large RA, large RV, significant TR, dilated pulmonary artery, all indicate severe pulmonary hypertension, D-shape, huge RV. You can see 4-chamber, septum shift to the left, IVC dilated, non-collapsing. So this is before treatment. See the pulmonary artery huge, and you can see the PA pressure without adding the right atrial pressure 94. So if we'll add 10, 15, so you are talking about RV systolic pressure of 120, and her systolic pressure is 100. So really she has suprasystemic RV systolic pressure. So this is a tissue Doppler. We are doing it to assess the RV systolic function. The red one here is the systolic, S wave. The blue one is the E wave, and this one is the A wave, like the pulse Doppler. So here, this normally should be more than 10. So here, almost 5, below 6. So it reduced. This one also is markedly reduced. And the deceleration time is also reduced, indicate very high right ventricular end diastolic pressure. This is a longitudinal strain of the lateral free wall. So normally minus 30. So here you can see very low, minus 12. This is a strain rate. This is very good for loading condition. This one here, the S wave, and here this is the E wave. And there is normal value for that. Okay, this is here we do the tracing of the RV function to assess global RV systolic function and to assess segmental RV systolic function. So we divide the RV into 6 segments: basal, lateral, mid-lateral, apical lateral, basal septum, mid-septum, and apical septum. And we can get the ejection fraction, segmental ejection fraction for each segment of RV, and we can do it also for LV. So again, this is 2D longitudinal strain. It's very low. And you can see the septum is contracting into the opposite of the lateral wall. This is a clear desynchrony of the RV. This will worsen the ejection fraction of the right ventricular systolic function. So that was before treatment. So when we start the patient, I start the patient on triple therapy. And I refer the patient to the rheumatologist. They give her, I think, steroid and cytotoxic drugs. Believe me, this echo after 1 month, you see the LV normal size, now no more D-shaped. You see almost round, still the RV is dilated. Exactly 4th chamber. You can see still RV dilated, RA dilated, and the septum is better. The TR is getting mild. It was before severe. And now the PA pressure dropped from above 100 to 37. And this is here the tissue Doppler. You can see the S wave improve. The E wave here improve. Longitudinal strain here is also improve. Strain rate, S wave, E wave, all improve. And here, the global ejection fraction now 44. It's definitely improved the RV systolic function, global as well as regional ejection fraction. And thank you very much. So I finished my presentation. Thank you very much.
Who's the chairman of this session?
Dr. Omar, you, Dr. Hisham, anyone.
Thank you so much.
I'm the next speaker, I cannot present myself.
Okay.
So
next speaker, I will, okay. Next speaker will be Dr. Hisham Hussein. Dr. Hisham, he is interventionist cardiologist in Saud Al-Babtain Cardiac Center. He's very senior intervention cardiologist. Hisham, I always, when I have difficult case, I ask him to do the right heart cath for me, despite he is very, very busy intervention cardiologist. He is also supporting us in LVAD cases and in also pulmonary hypertension cases. Dr. Hisham.
Thank you, Dr. Mustafa. And may I appreciate and thankful for the Saudi Association of Pulmonary Hypertension giving me this chance to share in this prestigious webinar, and thanks also to the organizing committee and the sponsoring company. May I share my screen with you? Can you see my slide?
Yes.
Okay. If you allow me, Dr. Mustafa, just to change the right heart cath to left and right, and I will tell you later why. Because the left is very important, and sometimes it is the bailout solution to get a proper filling pressure in the left ventricle. So we all know that the pulmonary circulation is a low pressure, low resistance, big capacity circulation. Even the histology of the pulmonary artery is different, with a smaller muscular layer, less muscular layer, more distensible than the aortic side or systemic circulation. So for a pulmonary artery pressure to rise, this will take a long time. And when it happens, this means you are a little bit late and you have to manage the patient earlier. Those are the normal pressures and saturations that we all know. You can see that the right side pressures is very low in comparison to the left side. Unfortunately, till now, with all the progress happened in the last years to treat the patient with especially pulmonary arterial hypertension, still we are struggling with the majority, which is group 2, 80% of patients with pulmonary hypertension. We are still struggling and trying to save those patients, and still the mortality is high among them. And all the medications that is dedicated to the pulmonary arterial hypertension, they are only for 5 to 10% of all these patients. So we have to clearly diagnose the patient before prescribing those medications that sometimes they are harmful. If you remember that those patients with the left side, I mean group 2 or group 3 lung disease, if they receive those medication dedicated for pulmonary arterial hypertension, they have harm, and you might make their course of treatment complicated. So before you treat, you have to properly diagnose. So where is the disease? The classification teaches us you have to define your way. Is it pre-capillary or post-capillary or combined? So if it is post-capillary, this makes easy for us. It is the heart failure patient, left-sided heart failure patients, either systolic or diastolic. They have high pulmonary capillary wedge pressure. If you are talking about also in addition to the class 5, they are considered post-capillary or combined. For group 1, which is primary pulmonary hypertension, group 3, which is the lung disease, group 4 with the thromboembolic, they are in the pre-capillary side. So those are the numbers. You are easily can get them from the right heart cath without the much colorful and sophisticated calculations by Dr. Mustafa. But the right heart cath, or right and left heart cath, they are very technically demanding. You cannot just simply put the catheter and read whatever wave you have or automatically let the device get you the numbers. You have to do it properly so you get a proper number and proper decision in step. So the right heart cath is to diagnose, and it should be done in the expert center that have experience. They are important even to follow the effect of treatment that you give, to assess if there is congenital anomaly that you have to deal with. It's important also if the patient is going for organ transplant. When you measure the pulmonary pressure, if it is unreliable, this is why I said the left side is also important. If you cannot measure the pulmonary wedge properly, because we saw a lot of reports getting rubbish waves as a pulmonary wedge waves, which are only damping of the pulmonary artery pressure and considering it pulmonary wedge. And I stress on this point because a lot of wrong reports come in this entity. So you have to make sure that you are properly wedged. If you didn't wedge, you simply go to the left side, get the filling pressure from the left ventricle, which is a very simple issue. And it's important also to have a differential diagnosis based on the result of the right heart cath. It's important also as a diagnosis and a treatment in the group 4 specifically, and we will see an example later. The right heart cath or right and left heart cath is also important for risk stratification, and it was previously mentioned in the wonderful talks by my colleagues. A lot of parameters mentioned, and one of them is the hemodynamics. If you get a right atrial pressure more than 14, you are talking about a high-risk patient with high-risk mortality. Taking in consideration that the patient during the course of treatment, he can wander between low risk, intermediate, and high risk, and back to intermediate risk, back to low risk, according to his clinical progress and response to treatment. So a repeat heart cath, when it is indicated, is also a risk assessment and follow-up for your patient. Those are the parameters that we are all know, that you got the saturation, you got the pressures in all these chambers, you can get the cardiac output, pulmonary vascular resistance, and response to vasoreactive when it is indicated. But also, in addition, it's not just numbers you are searching, or sometimes you are requested to get a coronary angiography. Why this is important? This is a patient that I did the day before yesterday. He's having biventricular failure, pulmonary artery pressure is around 70. It was important to assess the anatomy because if there is a surgical plan, is there any shunt through this coronary fistula? We have to rule out coronary artery disease. There is any anatomical relation, and I will give you a nice example between the coronaries and the pulmonary artery. Here is the example. This is a patient who indicated to have pulmonary angiogram because he's in group 4. the thromboembolic. So you can see in the left side picture the normal anatomy here, which is the relation between the left main and the pulmonary artery. If the pulmonary artery got aneurysmal and big, you might compress the left main. And this patient, fortunately, he had also the pulmonary angiogram showed that there is occlusion in the distal pulmonary segment zone, which was treated by balloon angioplasty to the pulmonary. And this relieved what you can see here, this ostial compression, external compression of the left main. This was relieved once they ballooned the pulmonary artery. So you have right and left catheter measures, numbers, you have coronary angiography, you have also pulmonary angiography when it is indicated. Remember that right heart cath is an elective procedure in most of the time. So the patient comes from home. So you have to do it, but take in consideration that the patient is a high risk patient. He's a heart failure, he's a high mortality patient due to pulmonary hypertension, etc. But in spite of that, you have to make it in a safe way. Big registry, number of patients, more than 7,000, reported to have an adverse event, which is 1.1%. So you see how low is that risk. And those risks comes from the venous access problem, pneumothorax, maybe the catheter mobility in the RV, which is very irritable and can cause arrhythmia, vasovagal reaction. Sometimes the pain in the patient's hand, if it's not treated well, they can get into hypotension easily, especially those patients have a poor RV or poor LV, and they can easily get into vasovagal. And most of these side effects or adverse events, they are reversible either spontaneously or with treatment. But it was reported during this 7,000 patients, they have only 4 patient fatality, which is the pulmonary artery rupture and electromechanical problem and intrapulmonary hemorrhage, which can easily happen if you are not taking your precautions, and I will tell you why. So the patient, usually what we are doing in our center, we have to evaluate the patient and rule out situations, clinical situations that might let you postpone the procedure, like the patient is anemic, the patient is active infection, the patient is having high bleeding tendency, he has electrolyte disturbance, and you will get and irritate the right ventricle, and easy you can have serious arrhythmia. The patient is dehydrated, and this will affect your numbers. If the patient is really dehydrated, that might hide a diastolic dysfunction that caused the pulmonary hypertension. The patient is having drug toxicity, you have to assess for that. Also, we should not forget the elephant in the room. Most of our patients is having oral anticoagulation in their treatment. For us in the center, we are dealing with patients less than 3.5 INR. Okay, we are using the arm approach, no problem, but sometimes you have to shift to a femoral approach. So you have to be cautious that your patient is already known that he's having a oral anticoagulant on board, and you have a strategy for that. If the patient is on warfarin, so the patient has to be shifted, stop the warfarin, get the INR lower, and transfer him to heparin as a bridge. If the patient on the other NOAC, so each one has its way of management. So don't forget, most of our patient is on oral anticoagulants, so we have to deal with this because a lot of bleeding happens and we miss out with our patients. So it's important also to make the patient not prolongedly fasting. Most of the patient, the nurse will easily keep the patient fasting since night. So he will come to the cath lab with a 10 hours, 12 hours fasting, everything, he's hypotensive, dehydrated. So sometimes you need to give a challenge test, fluid challenge. Sometimes we are doing it in the cath lab when it is needed. You have also to have a blood cross-matching. Maybe you need the blood for any reason. Our adopted axis in the center is the antecubital vein. I will ask my colleague in the anesthesia side, please get me a cubital vein, specifically if you can help me more, get the basilic vein, not the cephalic vein. Why? And there is other access route like femoral vein, internal jugular vein. For the basilic and cephalic issue, you can see here from this diagram that the cephalic vein is joining the axillary with an angle, like a hook. So this might cause you trouble during wiring. So I would prefer, and this is our practice, get the basilic at most of your cases, your life will be easy. The basilic is joining the axillary in an easy way, so you can go straight forward without problem. This is one of our patients done the day before yesterday. You can see here the radial sheath, radial artery sheath. We get the coronary angio done, we get the LV and diastolic pressure done easily, and the basilic vein for the right heart cath. And after we finish, simply you can see everything nice and the patient discharged on the same day. So this is to be considered. Also, if you have this patient have no veins, you cannot see, don't forget that there is ultrasound can help you, and our colleague in anesthesia, and inshallah in the future also will adopt the ultrasound guided puncture. Sometimes you cannot go through the arm. Either the patient have a previous accident, that's why the history is very important. Accident, he has a pacemaker in his pocket here, subclavian. He has thrombosis or breast cancer, and he received chemotherapy, lymphedema. So a lot of situation that you might be forced to go femoral. It's very important here. You will get numbers and waves. So you have to have the optimum situation to get those waves clear and your numbers correct. So you have to get good zeroing. You have to have the zero level at the mid-right atrium, and you have to put your catheter in the correct place, and always don't forget to flush. See here, this diagram, the level of the zero line is here. Suppose we put the level up by mistake, you see the pressure will be falsely lower than the proper one. So putting this transducer in the proper place will get you a proper number. So, and keep also the flushing alert. So this is our little toy, the Swan-Ganz catheter. Usually it comes to us from the MOH 7 French. So we are trying to deal with that. It's better to use a 6 French, but you are dealing with. Sometimes we are using this 6 French radial sheath that is 7 French from inside, and outside is 6 French. It's very nice from Tiromo company. And we need to get a good snip, dilate, get local anesthesia so the patient will not feel pain, and gradually upgrade your sheath from 4, 5, 6, 7, so he will not feel pain. The procedure should be totally painless, and this is what we are insisting for. Once you get your catheter in the proper place, and it's keep wandering back from the right atrium, right ventricle, pulmonary, and which you will have change of waves. And those waves should have been correlated with the ECG. People get rubbish waves and they don't correlate with the ECG. If you don't have, for example, the V wave in the atrial tracing just after the end of the T wave in the ECG, so you are getting nonsense. If you have a tall wave coming in the middle of systole, so this is not a V wave. So make sure that your ECG is clean, make sure that your waves are clear waves, and you will see the changes from the atria to ventricle to pulmonary. This is one of our patients. You can see here the puncture, the catheter coming from the vein, and down you can see the radial sheath in the single arm. And here the catheter is in the RA. And usually you keep the balloon inflated so you'll be away from the wall so you can get a nice sample and not a damped pressure. And this in this picture, you can see it is in the, almost touching the pulmonary artery. And this is the usual site that we inject the cool saline to do what is called the thermodilution method. And here you can see the wedge, which is here in the mid zone. We prefer it in the lower zone, but in this situation, it was in the lower zone, mid zone. So the pressure and waves, we have right atrial and right ventricular and pulmonary pressure. So the right atrium, usually when the valve is competent, it means a central venous pressure or RV end diastolic pressure, which is usually between 0 to 7. And this is the proper wave. The A waves come after the B. Sometimes it's absent in the patient in interfibrillation, and the V wave comes after the T wave in the ECG. So those are crucial. And the atrial tracing is the only tracing that have two positive deflection. So what causes the right atrial pressure to raise? A lot of things: myopathy, pulmonary hypertension, anything related to the pulmonary circulation or disease in the right ventricle will rise the right atrial pressure or hypervolemia. So regarding the right ventricular tracing, you will see a rectangular wave which gives you a systolic peak and the diastolic peak, and this is the RV wave, and with a late diastolic rise called the A wave. This is where we take the end diastolic pressure, not down here, it should be here. And sometimes the machine will take you in a false reading and measure other ways. So you have to get this A wave clear and the big systolic pressure. And you can see here, this rectangular is all systolic. So I'm pretty sure this is the right ventricle tracing. So the rise in the right ventricular pressure means what? Means pulmonary disorder, means diseases that affect the right ventricle. It's okay. Pulmonary vascular and pulmonary valve disorder affect the systolic pressure, while diseases in the right ventricle affect its diastolic pressure. Now the catheter with the inflated balloon in the RVOT, we have to fastly get into, no much delay, because you are sitting in the RV, you get into the pulmonary directly, and you will see the change in the wave. Usually the systolic is between 15 to 25, diastolic 8 to 15, and the mean should be below 20. And this is the pulmonary tracing. It doesn't have this criteria of the right ventricle we saw. It's just a systole, diastole with the acrotic notch, the closure of the pulmonary valve. So this pulmonary artery pressure can rise either acutely or chronic. And we are in the situation of chronic pulmonary hypertension, one of the reasons that we are here already. So the types, so when you see a high pulmonary artery pressure, it should lie in one of those 5 categories: the primary, group 1, 2 heart, 3 lung, 4 the chronic venous thromboembolism, and 5 is the miscellaneous. Very important, very important. The source of mistake in the right heart cath is the pulmonary wedge. If you are having the balloon inflated and you get into the pulmonary wedge to get the wedge, if you are wedged, you have to see the wave. If the wave changes to A and V waves, means you are wedged. If the wave is showing still that it is only a damped pulmonary, you are still in the pulmonary artery. If you deflate and the A and V wave change it to pulmonary tracing, this means you are where you were proper. So you go and get the A and V wave. And this is called the occlusive pressure, the pulmonary occlusive pressure. What this reflects, it reflects the left side pressure, because if we saw from the previous picture, it is when you occlude the pulmonary, you have a constant column of blood. You forget about the right side pressure. You are totally occluded, so you are not getting the right side pressure. It's totally reflecting the left side pressure if you are totally occluding it with a 75 to 10 to 100% inflation of the balloon. So it reflects the left atrial pressure, left ventricular in diastolic pressure. This is very important to take it in a supine position, take it at the end of expiration. And a lot of debates happening whether we take it spontaneously, but actually the end of expiration, the expiration time is more prolonged than the inspiration, especially in ventilated patients. You should take it in expiration because the ventilator will disturb your pulmonary wedge. And better to be in the lower lung zone where the pulmonary artery pressure is more than alveolar pressure will give you a correct number. The normal is between 6 to 15. So those are the zones. Better in that zone, you will get a more correct number. This is an example from one of our patients in the lower zone. So these are the pulmonary tracing, A and V wave, V after the T and A after the B wave. It should be like that. You should not accept other things. when the pulmonary wedge pressure is high, this gives you a possibility, mostly left-sided, systolic, diastolic, valve disease, cardiomyopathy, hypervolemia, shunt pericardial disease. If it is low, means the patient is hypovolemic or some obstructive embolus in the pulmonary. This is an example, what I said minutes ago. You have the pulmonary artery wave. Once you are wedged, it will change to an A and V wave, and you should be timing it with the ECG. Take an example on the right side. This is a patient who have pulmonary hypertension. You can see that this is a tracing of pulmonary artery reaching 100. And what he expected that he's wedged, he just have a damped pulmonary pressure. It's not wedge. And you can see the waves is not matching with the timing with the ECG. So it's rubbish. So in this situation, you should not force to get, you should try yourself to get the pulmonary wedge all the time. But if it's difficult, because why it's sometimes difficult, I will show you later. Sometimes it's difficult to get wedged due to pathology in the pulmonary artery. Also, don't forget to take it in the expiration. As we said, it will give you more stable line for the waves and proper reading. Here, if we can see the change that happens in the pulmonary arterial hypertension, the histopathology of the artery, you can see the artery changed from vasoconstricted to concentric thickening due to the hyperplasia in the muscles, and then the thrombosis. So if this is the size of the vessel and you are forcing to get into with the balloon, you might cause intrapulmonary hemorrhage. So if you are failing to get a proper wave, don't force the balloon, especially people getting deflated, and then when he wedge, he will inflate. He will get pulmonary hemorrhage. You should get with the balloon inflated inside the wedge place. If you didn't get a proper wedge, just go left, because you are searching for the left side filling pressure. So you just go to the left ventricle simply. So that's why we sometimes go to the left side, and you can get easily the left end-diastolic pressure at the E wave, and your life will be much easier. And of course, you can get also the pulmonary pressure. The other important data that we get out from the right heart cath is the calculation of the cardiac output and the pulmonary vascular resistance. There is two. I will not begin much in the math here, but we are usually using, unless there is a shunt, we are using the thermodilution method, where you inject the cold saline in your Swangans, the blue part which is opens into the right atrium, and it will, the cool blood, the cool saline will go to the thermostat that is in the tip of the catheter at the pulmonary, and it will check the change in the temperature. This is the position of the catheter in the right atrium. The cold saline will come here, and then it will travel and get the change of temperature at the tip of the catheter. And the area under the curve, once you inject, you will see this curve. The area under the curve calculates the cardiac output. We inject about 10 cc saline, 2 to 3 times to get the average. And this is how it looks in the monitor. The other Fick principle, which is calculating the oxygen consumption by the difference in the oxygen concentration, and it's direct method. And our colleagues in the pediatric, they prefer this method because of the shunt. The other parameter is the pulmonary vascular resistance. This is the core of this talk. If the pulmonary vascular resistance calculated more than 3 Woods, means there is a problem. It can help us in the diagnosis, and it calculates by pulmonary artery minus the pulmonary wedge divided by the cardiac output. So those are the normal numbers. Usually the pulmonary vascular resistance is less than 3, and the systemic vascular resistance is 10 to 15 Woods. The cardiac output 4 to 8, cardiac index 2.5 to 4. So those, now we had all the numbers that is needed. In all the groups, the mean pulmonary should be more than 20. Khalas, we have pulmonary hypertension. But how we can differentiate? By other parameters. Pulmonary wedge less than 15 means you are talking about pre-capillary. Pulmonary wedge more than 15, you are talking about post-capillary and the combined one. the whole story here, the mortality comes from the RV dysfunction. Those patients die due to RV dysfunction. So it's important to assess for our colleagues that patient will go for LVAD, like in our patient going to LVAD, I need to inform how is the RV function. The most two important parameters we are searching for is the cardiac filling pressure, RA divided by capillary wedge. It is, if it's more than 0.6, this means RV failure for the LVAD, or 0.8 for the acute. And the other most important is the pulmonary artery pulsatility index, systolic minus the diastolic pulmonary divided by the RA. And it is related to mortality. If you see here, this study, the baby, when it is more than 3.6, mortality is less than other patient having less than this number. And when you add hospitalization, the difference is so big. So it's very important to get this number for our colleagues assessing for pulmonary hypertension. The vasoreactivity test, I'll just mention in brief. Usually, it should be done in an expert center. Usually, it's for group 1 if we are going to have very minimal percent to have a calcium channel blocker responder. When it is positive, means the pulmonary artery pressure decreased by 10 or the absolute number got less than 40. Nitrous oxide, which we are using usually in our center, is recommended. There is other two alternatives, the ibuprostenol and the adenosine, and the inhaler. It's not recommended to use IV calcium channel blockers, and it's not recommended in other groups. Just skip. This is the way you are connecting to the patient, nitrous oxide source and oxygen source. And this is the console. This is when to stop if you have drop. And if you reach your target, it's fine. If you reach maximum dose, it's fine. And if there is any hemodynamic disturbance happen, you have to stop. Any glimpse for future facilities other than the right heart cath? It is the CardioMEMS. It is an implantable sensor that is inserted through the right heart cath bifemoral vein in the pulmonary artery. And this is a video I hope it will play. It's inserted through the femoral artery, and it's implanted in the pulmonary, and the patient can use it at home because he's by Bluetooth connected to a console and can send to his doctor all his pressure parameters and pulmonary vascular resistance, cardiac output. All these parameters can be sent smoothly, and no need to repeat the right heart cath. I hope we see this in our center soon. We can see here, I'll just make it forward. The patient is connecting himself to it, and by Bluetooth, he can send all the data to his doctor smoothly. So my take-home message that the right heart is truly a gold standard, but it's very, very technically demanding for measuring the hemodynamics. It's mandatory for diagnosis for our patient. It should be safe and informative. It's the knowledge, the knowledge of the modern management of our patient is markedly required, so you can follow up your patient in the proper way. And this is my last slide. Thank you.
Thank you very much, Dr. Hisham, for this excellent. I think the last speaker will be Dr. Nawal Al-Qubesi. Dr. Nawal, she is a consultant pulmonologist at King Fahd Military Hospital, Dhahran. And she has a special interest in pulmonary hypertension. Dr. Nawal.
Thank you, everybody. So the talk will be about pulmonary hypertension in pregnancy. Pregnancy is a so-called physiological process that affects different systems in the body, including the cardiovascular system. So there is a substantial increase in stroke volume and cardiac output that takes place throughout the pregnancy, but especially steeply in the first trimester. There will be also a drop in total pulmonary vascular resistance and physiological dilutional drop in hemoglobin, which is physiological. Pregnancy is also associated with hypercoagulable status because of increase in fibrinogen level and coagulation factor. and acquired protein C resistance and protein S deficiency. This will make them more predisposed to having thromboembolic phenomenon and more at risk of developing pulmonary hypertension. So it's not only pregnancy, but labor and delivery can make us facing treatment challenges in these patients. In hemodynamic aspect, we can have hypotension because of significant blood loss and exposure to anesthesia during C-section. And there can be a significant increase in blood volume because of the sudden IVC relief and the blood returning from the contracting uterus. And we can complicate this and make it worse by iatrogenic fluid intake. So morbidity and mortality can happen throughout the pregnancy, labor, or postpartum. And actually it was reported that most of the mortalities happen 1 month postpartum. Initially or earlier, historically, the mortality reached up 30% and even more if we have other associated causes of pulmonary hypertension. But it was noticed that over the decades, it was slightly improved, but still substantial. Like it dropped from 30% to 17%. There were reports that calcium channel blocker responders had better prognosis during pregnancy. Some of the recent studies, one published in 2016 European Respiratory Journal, it was a multicentral study. It was prospective that monitored 26 PH patients from year 2007 to 2009, and the mortality rate here was, or the percentage was 11%. There was 1 urgent transplantation, 2 spontaneous abortions, 8 induced abortions with 16 successful pregnancies. If you have a look at the second row in this table, you can notice that the calcium channel blocker responders had the better or the best success rate of pregnancy. There were no deaths, no transplantations, and no need for induced abortions. In Chest Journal, they reported or they published a study that took place in 5 centers over a decade, monitoring 18 pregnancies with pulmonary hypertension, and the death percentage was 17%. Another journal monitored around 36 pregnancies, published a study that monitored 36 pregnancies, again over a decade time. And the mortality rate in this case was around 8%, which is less than the usual rate of mortality in pregnancies. They varied between group 1 to group 2 and group 4 of pulmonary hypertension. The median pregnancy time was chosen to be 24 weeks. They also noticed that the mortality rate in patients who received general anesthesia during C-section was as high as 19%. In the American Heart Association journal, this was published in 2017, they observed, it was actually a national study, a big study. There were 7,000 pregnant women, 1,000 of them had pulmonary hypertension. 60% of those patients with pulmonary hypertension had isolated pulmonary hypertension, while the pulmonary hypertension with cardiomyopathy and valvular heart diseases. And in that study, they found that the highest major advanced cardiac events happened in patients with pulmonary hypertension with cardiomyopathy and valvular heart diseases rather than isolated pulmonary hypertension. They found also pregnant women with pulmonary hypertension were at more significant risk of eclampsia syndrome, preterm delivery, and intrauterine fetal death. In that particular study, they concluded that the prognostic factors for pulmonary hypertension and pregnancy were the severity of pulmonary hypertension, and there were several other papers that found a correlation between the PVR and the prognosis of pregnancy and pulmonary hypertension. Delayed diagnosis of pulmonary hypertension was associated with the worst prognosis. The worse the functional class was, the worse was the prognosis of pulmonary hypertension in those pregnant patients. Regional anesthesia seemed superior to general anesthesia for cesarean section. Combination of pulmonary hypertension and cardiomyopathy was associated with worse prognosis. And as we have mentioned earlier, calcium channel blocker responders seem to do better in terms of pregnancy. So it seemed to be black and white. Pulmonary hypertension patients should avoid pregnancy, but unfortunately, life is not that way. There is always this shade of gray, because pulmonary hypertension can first be diagnosed during pregnancy. Pregnancy can unmask a diagnosis of pulmonary hypertension, or maybe it's a case of contraception failure, or it's just the patient's choice to go on with pregnancy. So very recently, I received a patient, but thank God after the storm has settled, she's a 26-year-old lady who studies abroad in US with her husband. And in August 2019, she showed up in a center there, pregnant, with her very first pregnancy, 18 weeks pregnant, complaining of exertional dyspnea, function class 4, pre-syncope, and lower limb edema. Prior to that, she was not known to have any chronic illnesses, but she was overweight, and she gave history of using medications trying to lose weight, but we don't know whether they were anorexiogenic medications or not. She had symptoms suggestive of obstructive sleep apnea, but no official test was done. In terms of saturation and hemodynamically, she was relatively fine. When the echo was done, according to the reports, the systolic RV pressure was 110 with moderate impairment in the RV function with normal left side. And according to the reports, unfortunately, I didn't have the tracings, but her mean pulmonary artery pressure was 90, and the right atrial pressure was 8 with a normal wedge, and a PVR that is around 17 Wood units. The cardiac index, interestingly, was not that bad. So they labeled her as a pre-capillary pulmonary hypertension group 1, most likely functional class 4, and definitely high risk and pregnant. So they opted to admit her to ICU, optimize treatment, start her on IV epoprostenol, and she was discharged after the IV line was secured. She was started on subcutaneous enoxaparin. She was delivered with a scheduled induced labor, vaginal delivery, and she received epidural anesthesia. Post-delivery, she was started on sildenafil, ambrisertib, and epoprostenol was started to be tapered off because she was traveling back here. They didn't know what the situation will be. How would she handle the IV line emergencies? The sudden discontinuation of the medication can be really fatal. And once she delivered, and the CTPA and BQ scan were normal, so they just stopped the anticoagulation. Her connective tissue disease workup was negative. Her thyroid function test was normal. HIV, hepatitis profile were all negative, and her CT chest showed the classical mosaic lung appearance and pulmonary vascular diseases, and her CTPA-VQ, as we mentioned earlier, was normal. So she showed up in September 2020 with a healthy 10-month baby. Her symptoms were much better. She was in functional class 1 to 2. She had no more pre-syncopes. Despite she still had that chest tightness, her blood pressure was on the higher side. This time she was still overweight, and apart from loud P2 on auscultating her precordium, she did not have any abnormal physical signs. Her BMP was 18. We're still waiting on her sleep study and pulmonary function tests and 6-minute walk test, but we have a cath, a latest cath from June 2020, where her mean pulmonary artery pressure showed some improvement, dropping from 90 to 64, and still with a normal wedge, and improvement in her cardiac index. But the PVR, despite dropping from 17 to 9, it was still significantly high. Her echo showed some improvement, but still the RV showed mild systolic impairment. So at this level, I think she will still need prostacyclin agent, probably Uptravi or selexipag, or probably should go back to using parenteral prostanoid agents. So the challenge with pregnancy, and as mentioned earlier by Dr. Dolan, the symptoms of pulmonary hypertension are non-specific, and it can happen with pregnancy, the shortness of breath, the dizziness. And there is always a reluctance with using fluoroscopy with the right heart cath. There is this general idea that it's risky for the baby and for the mother. Now, and as Dr. Rifai presented, the echocardiography can be an excellent screening method for pulmonary hypertension, but still the guidelines are not recommending it as a gold standard diagnostic method. And there were papers that said that echo sometimes overestimated the diagnosis of pulmonary hypertension, probably because of elevated cardiac output in women, in pregnant women. So in 30% of the cases, right heart cath saved women from a drastic measure of pregnancy termination, which can be an option when you find out that your PH patient is pregnant. So right heart cath is still the gold standard. Now, what's the fear of this radiation? So the maximum safe dose that the fetus can be exposed to is 50 milligray. Some references mention up to 150 milligray. From 100 to 500, they are exposed to embryonic death and malformation. Let's see the standard radiological procedures and how much radiation they can expose the patients to. The highest radiation dose from an X-ray, a plain X-ray, comes from the lumbar X-ray to the fetus, and the dose is only 10 milligray. Remember, we said that the maximum safest dose is 50, so it's still within the tolerable range. Pelvic CT scan expose the fetus to 50 milligray, which is in the borderline of the maximum safest level. Now, Seriate and Gray measure two different things. So saying that diagnostic angiography gives you an equivalent dose of radiation of 1 to 7 millisievert does not really help us much. But there was this article that looked at the practice of interventional cardiologists doing coronary angiography, which is more historically done and more probably often done. So they looked at the practice of doing the cardiac cath before year 2000 and after year 2000. And they found that interventional cardiologists nowadays managed to minimize the fluoroscopy time from 6.2 minutes as average to 3.7. And with that, there was a reduction in the radiation exposure. So probably with just doing our best and minimizing the radiation exposure during the right heart cath, eliminating the magnification or just reducing the magnification and giving pulse fluoroscopy rather than continuous fluoroscopy can help. Can we do right heart cath without fluoroscopy, just being guided with the tracings? It can carry its risks, and probably our colleagues in cardiology do that. I would never do it without fluoroscopy guidance. There was this statement from PVRI that said, well, right heart cath probably is falling out of favor in critically ill patients because of complications and risk for the mother and fetus. Yet still, it's the gold standard diagnostic tool. Well, in order to reach a diagnosis and risk stratification, I mean, etiological diagnosis, you need to do other imaging tests and some blood and biochemical tests that was mentioned by Dr. Dolan to reach a classification to which group does this pregnant pulmonary hypertension patient belong to, just like any ordinary pulmonary hypertension patients, and just like Dr. Hussam earlier talked about the risk stratification. Now we talk about management of these patients. Now, first line and the cornerstone management of a PH patients when it comes to pregnancy is not to get pregnant. So if you have your female patient diagnosed pulmonary hypertension, it's better to advise her early on for a combination contraception method. We have the barrier method, which avoids the side effects of OCPs, but it's still unreliable, and the progesterone-only preparations, OCPs, which avoid the estrogen thromboembolism risk, but you need to alert your patients who are on bosentan that bosentan may reduce the efficacy of these agents. And we have the hormonal IUCD, but again, it may not be tolerated by PH patients as it may induce vasovagal attacks. So the definite solution probably is just sterilization and tubal ligation. Some papers said that because of more controlled settings, doing it with mini laparotomy can be safer than laparoscopic procedure. And also there is the option, if the partner is willing, for male sterilization, which is much safer and much cheaper. Now, if the patient does get pregnant, then you still have the option of terminating the pregnancy, especially before 22 weeks, where the risk is still low of the termination procedure. Overall, there is no standardized approach so far to treat pregnant patients with pulmonary hypertension. The management is individualized and tailored, but the main component is it has to be in an expert center, and it has to be multidisciplinary with the approach from the obstetricians and the pulmonary hypertension specialist and physiologists if needed. So it's advised to have elective admission earlier in the diagnosis for the optimization of the treatment with regular close follow-up with echo and fetal monitoring for intrauterine growth retardation. It's important to manage the hyperemesis gravidarum because it may affect the absorption of the medications, and the delivery has to be scheduled. Don't just leave it spontaneous. The basic overall approach in managing RV pulmonary hypertension is maintaining an RV function and reducing pulmonary vascular resistance. So you need to handle your fluid management carefully with diuresis, hemofiltration, and close hemodynamic monitoring if needed. When it comes to medications, the target medications, calcium channel blockers are category C in pregnancy. Endothelin receptor antagonists are category X. They are contraindicated. Prostacyclin pathway medications, IV epoprostenol is category B. Again, we only have case reports, and when it comes to pregnancy, we don't have studies. So it's usually used several weeks before, or even before that, near the time of delivery. Patients need to be monitored for bleeding risk because it may inhibit platelet aggregation, and the nebulized iloprost is category C. Selexipag or Uptravi is still not known. So it's better to avoid it in pregnant women. Sildenafil is category B. Riociguat is category X, by the way. Inhaled nitric oxide can be used in ICU settings, and you just need to watch for methemoglobinemia. So when you have a patient who's already known to you as pulmonary hypertension and they become pregnant, you just continue them on whatever medications they were maintained on, except for endothelin receptors antagonists, because they are category X. But if they're new, then probably your first option of treatment is to put them on IV epoprostenol or sildenafil. Anticoagulation, use it as prophylaxis. If there are CTEPH patients, use the therapeutic doses, but you avoid warfarin because of its known teratogenicity. Delivery, there is no ideal mode of delivery. We said that it's tailored and individualized. Spontaneous vaginal delivery has the advantage of minimizing post-surgical fluid shifts and anesthetic risks. You avoid fetal compression of the inferior vena cava. C-section has the advantage of more controlled settings. It avoids the prolonged second stage labor and the potential for uncontrolled vaginal hemorrhage and the adverse hemodynamic effects of bearing down. When it comes to anesthesia and C-section, using combined spinal and epidural anesthesia is preferred because you get a better sensory blockade than epidural anesthesia alone, and there is no additional risk of hypotension if you give only low dose of a spinal anesthesia when it's combined with epidural anesthesia. General anesthesia is better to be definitely avoided. Just like any critically ill patients with pulmonary hypertension, there's the option of ECMO and lung transplantation. Breastfeeding is better to be avoided because most of these medications are excreted in milk, and because of prolactin and oxytocin effect on the hemodynamics. So despite that, there has been an improvement in the mortality rates in pregnant women with pulmonary hypertension over the last decades. Still a significant mortality rate. It's still not neglectable. So it's still advised that those patients should not get pregnant. When they do, then determination of pregnancy in the right time is the best option. If they do continue with their pregnancy, then the management should be in expert centers, tailored, individualized, and multidisciplinary. I hope I finished on time, and thank you.
Thank you very much, Dr. Nawal, for this excellent presentation. So, yeah, maybe Hisham, you can check the questions.
I already answered some of them.
Can I start with questions?
Yeah, sure.
Okay.
So I'm so happy that we have cardiology colleagues here talking about right heart cath and echo, and so thank you so much for enlightening us in that regard. So Dr. Hisham, sometimes I face very rare occasions, but it happens, difficulty in advancing the cath to the pulmonary artery when I'm approaching from the femoral approach, which is the easiest for me as a pulmonologist and a cardiologist. So do you think that changing the approach would make it easier to overcome that resistance, especially in cases with very severe tricuspid regurg and very dilated RV? Do you think just probably approaching it from jugular axis will make it easier to approach the pulmonary artery in cases of a very severe tricuspid regurg and the very dilated RV? That's one thing. And the other thing is regarding thermodilution and indirect FIC. You said that if thermodilution is not accurate, then we should use indirect FIC. I thought it's the other way around, that if indirect FIC,
maybe you got me wrong. Maybe you got me wrong.
Oh, okay.
If I may answer the first question, usually coming with the flow is easier for you to go through the tricuspid valve. If you are coming from the right atrium from above down in the direction of the flow to the tricuspid valve, your life is much, much easier. If you are coming from the inferior vena cava, you have to make a loop, and then the tricuspid regurg will kick your catheter away, will not allow you to get easily, and you have to make a lot of friction with the right atrial wall. I do recommend, I don't know how easy it is, just let your anesthesia colleague put a cannula in the basilic vein or cubital vein. Your life totally easy. Avoid jugular because bleeding is like hell. So if you go through the cubital vein, very simple, just pre-dilate from 4 to 7 French, so the patient will not feel pain. And the catheter, I didn't face any problem with the tricuspid regurg going from the cubital vein. The catheter, you inflate the balloon, it will go smoothly up to the wedge. So this is one. Remind me for the other question. Yeah, maybe you got me wrong. The thermodilution, there is a study which I missed I passed the slide. There is comparison between thermodilution and the FIC method, and they found that the thermodilution is more predictor of mortality than the FIC method in reasonable percent. the thermodilution, we prefer it as long as there is no intracardiac shunt, because it depends on the temperature change. But if there is shunt, it will disturb this principle and it will not be working. So you have to go through the FIC method. That's why our colleague in pediatric prefer the FIC method, because it's more accurate in the presence of shunt. But the standard, we are using the thermodilution. Sure.
Thank you, Dr. Mustafa. Just two questions. So you mentioned the two-dimensional imaging. I believe it's just extracted from the echo. Is this the way, or I'm not really sure that I get it? And do you think that in the near future we can just get rid of the, well, not get rid of it, but at least consider echocardiography as sufficient diagnostic tool for pulmonary hypertension? And the other thing is, it's another question. I face it, especially here in the Eastern Province. We have lots of hemolytic anemias, and they get this false positive study, echo study for pulmonary hypertension, when it's done while they're actively hemolyzing. So when we repeat the echoes later on, when the hemolysis is gone or settled or managed, the pulmonary artery pressure, systolic pulmonary artery pressure, come back to normal. So do you have any explanation for that?
Yeah, for the first questions, for assessment of the right ventricular function. I think there is a lot of, before the RV, there was no much things to assess, but now there is a lot of things to assess for the right ventricular function. So we can get the RV ejection fraction. We have to get the fractional area change. We have to measure the size of the RV at the base, mid, apex. Now we're getting the TAPC. But the problem of the TAPC, you are only assessing 1 point. 1 point. So this 1 point does not reflect the whole point of the RV. Now with the speckle tracking, and now most of the big company like Philips, GE, Siemens, they have software called speckle tracking. So you can track the right ventricle and get a global ejection fraction, get segmental ejection fraction, get ejection fraction of the septum at 3 level and the free wall at 3 level. And you can get the global longitudinal strain, and you can get the strain rate. So this is from 2D. Now there is a new software for GE, Philips, Siemens, and also Toshiba to use 3D. So you can do real-time 3D volume. And they put a software. You just put 1 point in the annulus, 1 point at the medial, 1 in the lateral, 1 at the apex, and you press for the 3D volume. And you will get the diastolic volume, systolic volume, and can give you the ejection fraction, and can give you the longitudinal strain. So, and it is, it will take, it's not time, it will take only maximum 1 minute to 2 minutes. You just do, you should just have the software in the, and you can do it offline. You can do it on the machine and you can do it on the workstation. You can do it, I have patient had echo 10 years ago.
Oh, interesting.
And had echo 1 week ago. So I can do it for all these things. I can see how the dropping in the ejection fraction or improving with treatment. So I think technology is getting better. And I have a feeling I always fight with the interventionist. Now I know every meeting you go, everybody say the gold standard is right heart cath. But unfortunately for left heart cath, for valve, I don't send the patient to the cath. If I have a patient with severe mitral stenosis, I don't send patient to cath unless he's for coronary before surgery. Mitral regurg, I don't send patient for cath, despite they have significant pulmonary hypertension. Most of the valvular heart disease, we can do it by echo. We can do the PA pressure, the peak, the mean, the resistance.
So hopefully we can collect data and present it to the international societies. We may convince them that we can save patients the invasive right heart cath procedure with more advanced echoes.
Hisham knows 90% in the cath lab doing coronary and BCIs. Busy. So, but for echo, you just to have an interest and to have the software, the tools, and you spend your time in the dark room with all software in a good coffee and do all your calculation.
So
may I add here, Dr. Mustafa, if you allow me, Dr. Both of us are targeting the benefit of the patient. And if you have at any time doubt in your data or it's not matching with his clinical scenario, you will have to go to the invasive. And now you can see we are trying to make it painless, arm approach, patient go in the same day, all venous access, radial access. So even the invasive is coming less painful, short hospital stay, it's a day case. You have good numbers, clear numbers, you can take decision. But you will not go for cath for all patients. You have, when you are taking major decisions that might twist the outcome of the patient, you might go for. But for sure, the echo is a great tool and safe tool, and you can repeat it whenever you, without any burden on the patient.
بس اسمحوا لي بس two comment, one questions بالنسبة للدكتورة نوال. How many patients you face with them and you discuss with them not to get pregnant, and they come to you later on with as a pregnant? This is one question. And I want to comment on no fluoroscopy for right heart cath. And most of the, if you know that most of the cases is the anesthesia in the OR, they put a right heart cath, and usually they don't using a fluoroscopy. So doing a right heart cath, if you go from the internal jugular, it's easier. You can try it without fluoroscopy. Even if you do fluoroscopy, it is very minimal fluoroscopy. You don't need a lot of the fluoroscopy, and you can go by tracing. In ICU, we sometimes used to do a right heart cath in children in the ICU without fluoroscopy. We just go by trace. You can see the arterial trace, ventricular trace, and go. Going from the neck is easier because when the tip of the catheter reach the RF apex, it will just loop and go directly to the abdominal artery. Coming from the femoral artery is challenging in crossing of the tricuspid valve, and sometimes it's also to go to the BA, and sometimes you have to use the catheter wire. It's like trauma wire or something to help you. But yes, I agree. The last thing is thermodilution. If you have the breast function and severe TR with this, like what we are seeing in patients with advanced pulmonary hypertension, I didn't know the thermodilution will give you the right number or not, because the TR will affecting your thermodilution, and it will be giving you sometime false low or false high. I will leave it for Dr. Hisham. Maybe he will comment on that. How severe the TR you accept before you go and do thermodilution. For FIC method, I will just 1 minute. For FIC method, it is a standard for number. If you keep using the same number, even if it's not accurate, you are using it the same time. But it's not a FIC method like now we are using 100 oxygen consumption, and in the other cath we are using 120 and someone else, and this is maybe a different. Okay, thank you.
Regarding the thermodilution, if you are going with the catheter and you don't have that impression, severe tricuspid regurg like flail leaflet, you don't have that much kick out of the catheter from the right ventricle to the right atrium, and you go smooth, and you feel that your Cole's line will go smooth. But if you have difficulty in huge right atrium, huge right ventricle, and you have difficulty, for sure, your saline will not reach. It will be reflected, and you have to go for the other method to confirm. And plus the echo beforehand, also you have an information. So it's a gathering of the information. You failed with one tool, you have to go to the other tool to get the correct answer. You don't rely on one method, for sure. This is true.
Yeah. Last question, maybe.
I'm waiting for Dr. Nawal to tell me about how many she counsel and they don't listen. Because they have the problem with the lady. They never listen. Yeah. And they get pregnant.
Okay. It's a big social problem.
Yeah, really. I spoke with them and they get pregnant. And they come pregnant, even with the adult congenital. We advise them not to come. And they come pregnant. And I appreciating the issue, really, Dr. Nawal. Sometimes they are under pressure from a lot of social things. Go ahead.
In my personal experience, they were all first diagnosed while they were pregnant. So they were counseled for termination of pregnancy, which is even harder. One of my patients was found to have pulmonary hypertension while she was engaged, so the fiance left her. So that was a bit traumatic, but the rest of them insisted on continuing their pregnancy, and all of them did fine. Now, you know, it's difficult because the future of PH is changing, and as you have seen that we have more recent studies showing there is some improvement in the outcome of pregnancy and pulmonary hypertension. But since these are just case studies, they're not systematic studies, they're case series, I mean. So we still cannot conclude solid information from these. And it's our duty always to counsel them and do our best, not just to talk in the clinic, a short talk and say that I did my job. Psychologists, like we mentioned, that it's multidisciplinary approach. So psychologists and social workers should be also involved. Lots of religious and social dynamics are there in the system, and especially, you know, I practice in Vancouver. It's different from here because in Vancouver, women have the option of adoption, and it's not as easy as it is there here. So again, we'll still have a long run in controlling that.
Thank you very much.
Thank you. There is one question. If you have a patient with COVID-19 positive with pulmonary hypertension, so how we will approach this patient? Severe pulmonary hypertension and COVID positive.
يعني هو already diagnosed ولا he's on treatment?
If he is COVID positive and the physician suspect there is pulmonary hypertension, so how can we confirm the diagnosis and guide the management for COVID patient?
Well, I'll talk from our center experience, and of course you can talk from your experience, and we still proceed with doing the regular workup, the echo and the right heart cath. We usually leave them, the last patients, to be scheduled, so the sterilization process can take place properly, and the ultrasound or the echo machine, they have already just specified one for the COVID ward. We have a special COVID ward, and with all of its equipment, with their ultrasound abdomen. Or in terms of managing them, we just, as everybody knows now, they are vulnerable in terms of volume overload and diuresis, and so we need to be careful with managing their fluids and putting them in close hemodynamic monitoring. And we have very low threshold of transferring them to CCU or ICU in comparison to other patients with no comorbidities.
may I add here to Mustafa, yani, if you have a patient with pulmonary problem, yani, you should not, and we mentioned that in our patient evaluation and preparation before right heart cath, you should not go to right heart cath taking a critical decision while your patient in sepsis. So what is important comes first. Yani, now treat him first and then take the decision in a later stage. I think this will be much wise. And you question whether his pulmonary disease is responsible for this pulmonary hypertension, or was before presented and the COVID is something just he faced recently. The scenario also is very important. So no need to go with a patient with sepsis and do him right heart cath or any invasive procedure, even stenting or whatever, unless it is a life-saving.
Yeah, and I agree with you. If you can, guys, explain this to me. Usually the echoes done bedside in critically ill patients in ICU are not that accurate. Most of the time, when we repeat them, when they're out of the acute illness and they're more stable, their echoes normalize. And as I've mentioned earlier, if there's an explanation for those patients coming with hemolytic crisis, the sicklers coming with hemolytic crisis, most of the time their echoes show false positive pulmonary artery pressure elevation that normalizes later on when they're out of their hemolytic crisis. So yeah, there is no rush unless it is the major cause for their hemodynamic distress. Then
I think I agree with you. Yani, doing the echo during hemodynamic instability is not the same as you read the echo in a very stable patient. That's why always we ask the technician to write in the report, what is the blood pressure? Suppose the blood pressure is 70/30. Is the hemodynamic will completely different than a blood pressure of 130/70. So putting blood pressure, heart rate, fluid status, hemolysis in case of sickle cell, all is really important in giving the assessment. Okay. Okay, so at the end of the day, I really want to thank all the speakers, all the audience, and the Johnson & Johnson and the Ritage Company for sponsoring this excellent webinar. Tomorrow we will meet at the same time. Tomorrow in the morning we had 3 sessions about lung disease, group 2, pulmonary hypertension, and group 3, and also connective tissue disease with pulmonary hypertension, pharmacology with pulmonary hypertension, and the last we have interesting cases, congenital left heart, and case from Dr. Dal'an, chronic thromboembolic disease. Thank you very much and have a nice night. Thank you.
Thank you.